それでは定刻となりましたので、
Since it is time to start, we would like to start the 2025 Fukushima Medical University International Symposium on the Fukushima Health Management Survey, Fukushima's Lessons for the Future, Promoting Health and Responses to Disasters. And now, the Professor Mallet Kenneth will be serving as Master of Ceremony, and he's from Radiation Medical Science Center for Fukushima Health Management Survey.
Welcome to the 2025 International Symposium on the Fukushima Health Management Survey. Today's hybrid symposium at Fukushima Medical University's School of Health Sciences includes online participants from around the world. Hello, I'm Kenneth Nolet, a resident of Fukushima continuously since 2008 and a permanent resident of Japan since 2020 because the Japanese way of responding to disasters and more recently to a global pandemic makes Fukushima my best place to work and to live. Another good thing about Japan is the hard work of honest, independent media. Today's attendees include reporters, journalists, and videographers. We are grateful for your time, your attention, and your service to readers, listeners, and viewers around the world. Let's begin with words from FMU President Takenoshita Seiji, whose prior service as hospital director and vice president guided much of our response to the 2011 earthquake, tsunami, and nuclear crisis. President Takenoshita.
Thank you very much for your introduction. My name is Takenoshita of Fukushima Medical University. And for the 2025 International Symposium, I would like to offer a few words. First of all, I would like to take this opportunity to express my sincere gratitude to the many people who have extended their kindness and support to us in the implementation and operation of the Fukushima Health Management Survey as we approach the 14th anniversary of the Great East Japan earthquake. And this is the 7th symposium. And from in and outside of Japan, we have so many participants today. Thank you very much. After the earthquake, our university was quick to declare that we would support the recovery of Fukushima from the aspect of health and medicine. Since that time, in addition to its original mission as a medical university of education and research and medical care, we have fulfilled our historical mission of looking after the health of the people of Fukushima. And 14 years since the earthquake have been a series of new challenges and trials and errors for the university to achieve these missions at the higher level. The reconstruction effort that we have made with a sincerity in the difficult environment are now entering into the new phase for the next generation. And to this end, the university is currently collaborating with the Fukushima Institute for Research, Education and Innovation, FREI, in order to resolve these issues. And we actively accumulate and disseminate the data and findings related to the nuclear disasters. As for the international academic exchanges, a memorandum of understanding was concluded with the Harvard T.H. Chan School of Public Health last September to promote analysis and the other activities related to the responses and challenges after the nuclear accident. As a fruit of that, just last month, in January, winter session Fukushima field trip was conducted for about 3 weeks. And 15 graduate students visited from Harvard, our prefecture, to deepen their understanding and responses and challenges after the nuclear power plant accident. They visited various places, including the Great East Japan Earthquake and Nuclear Disaster Memorial Museum and Fukushima Daiichi Nuclear Power Plant, and the universities in the prefecture. We have also gave the lectures for them. And we believe that we can widely communicate what Fukushima is doing today for the reconstruction widely through this program. And this program will continue. We will proceed with the earthquake-related researches rooted in the region through mutual student visit and activities. And these earthquake-related researches will be further advanced. And today's symposium, entitled Fukushima's Lessons for the Future, Promoting Health and Responses to Disasters, will present the scientific findings from the survey and perspective on how to apply them in the future. We hope that the researchers participating from Japan and abroad will engage in a lively discussion and offer their perspectives from their expertise. I wish this symposium to be a meaningful occasion for all of you who are participating today. Thank you very much, and thank you once again for coming to this symposium.
Thank you, President Takenoshita. Next, Fukushima's Vice Governor, Sato Hirotaka, will deliver a message on behalf of Governor Uchibori Masao. Vice Governor Sato.
皆様こんにちは。
Good afternoon, everyone. My name is Sato. I'm a Vice Governor of Fukushima Prefecture. Because of the public service, Governor Uchibori cannot attend, unfortunately, in this symposium, so I would like to read his message on behalf of him. On the occasion of a 2025 Fukushima Medical University International Symposium on the Fukushima's Health Management Survey, I would like to extend my greetings. We are grateful that there are so many participants today from Japan and overseas. I would like to express my sincere gratitude to all of you for your effort for the reconstruction of Fukushima through your research and survey activities, and for your continued understanding and support of our prefecture. In Fukushima Prefecture, after the accident at TEPCO Fukushima Daiichi Nuclear Power Plant, we are conducting Fukushima Health Management Survey with the cooperation of Fukushima Medical University in order to maintain and improve the health of all residents of the prefecture into the future. As 14 years will soon pass since the nuclear power plant accident, we hope that this symposium will introduce the accumulated scientific findings from the Fukushima Health Management Survey and deepen the discussion through an open lecture to be attended by prefectural residents, so that the latest information on the Fukushima Health Management Survey will be widely disseminated, both domestically and internationally. The prefecture will continue to work closely with the Fukushima Medical University to ensure that safety and security of the people of Fukushima Prefecture, and we ask for your continued support in this endeavor. In conclusion, I would like to offer my best wishes for a fruitful symposium and for the continued good health and success of a participant, including those participating online.
ご活躍を心からお祈り申し上げ、挨拶といたします。令和7年2月20日
February 20th, 2025. And I read on behalf of Masao Uchibori, the governor of Fukushima Prefecture. Thank you very much.
Thank you, Vice Governor Sato. Next, it's a pleasure to introduce FMU General Vice President Oto Hitoshi, whose biography appears on pages 8 and 9. As a professor emeritus, Dr. Oto helps direct the Fukushima Health Management Survey while continuing to be active in the academic specialties of blood transfusion and perinatal medicine. Professor Oto.
ノレス先生、ありがとうございます。
Thank you, Dr. Nolet. We will go on to the Dr. Yasumura's lecture. My name is Oto Hitoshi, acting as the chair. Dr. Yasumura laid out the grand design of Fukushima Health Management Survey, FHMS. His specialty is public health. He truly resonated with the resident and laid out the grand design of the FHMS, Thyroid Ultrasound Examination, and other detailed surveys. He has kindly laid out the grand design. Thank you. My name is Yasumura. Nice to meet you. Today, by way of introduction, I would like to give you the overview of Fukushima Health Management Survey as the introduction of the following presentations. There are 4 topics I'd like to cover today. The first one is a nuclear disaster after the Great East Japan earthquake and its impact on people. 2, overview of the FHMS, and 3, health effect evidence from FHMS, and 4, future focus. We call it, as Dr. Oto also mentioned, we call it a survey as we commissioned it from the prefectural government. Its ultimate goal is to give support to the resident. They have suffered a great impact from the disaster and the tsunami, including mental pressure. We draw insight from FHMS, and the ultimate goal is to offer support to resonate with the resident. I just wanted to add this comment prior to my presentation. The first topic is nuclear disaster after the Great East Japan earthquake and its impact on people. This shows the air dose 1 month after the disaster. First, the radioactive substance was released and flew to northwest and then to the south. The evacuation zones are designed in a way according to the radius from the Fukushima nuclear power plant. The deaths in Fukushima, the direct death toll, is relatively small compared to that of Iwate or Miyagi Prefecture. But the true issue in the Fukushima Prefecture is not the direct death toll. There is indirect death or death caused by disaster-related causes. I'd like to emphasize here, aside from direct deaths, there were deaths caused by the nuclear power plant accident, so we call it a triple accident. But Let me emphasize here again that there was no death caused by radiation.
ご理解いただきたいなというところであります。今申し上げましたように、亡くなった方、直接
As I mentioned earlier, the total mortality is direct death plus indirect death. According to the central government data, Fukushima's total mortality is quite high, even compared to Iwate and the Miyagi prefectures, which means that the Fukushima people have suffered long-lasting impact, which could deteriorate their existing medical conditions. And Fukushima has more disaster-related deaths, predominantly among older citizens.
高齢者であるということが大きな特徴であります。で、これは今も続いているという
And the impact is even still unfolding now and giving us long-lasting challenges.
震災後、直ちにですね、福島県は
Right after the disaster, Fukushima Prefecture set up a center at the Fukushima Medical University to protect resident health.
言ったんですけれども、大きく2つの目的ということで
Fukushima Health Management Surveys
一つは長期にわたる県民の
aim for
による
relieving anxiety after the nuclear accident and protecting and promoting the long-term health of Fukushima residents.
前段で最初に書いてある不安の解消というのは目的としておかしいのではないか。
After setting the objectives, though, we thought that if it's really okay to act to relieve anxiety, because it's natural to feel anxious about such a great disaster.
調査の目的には将来にわたる
Now, the goal has been somewhat redefined to protect and promote the long-term health of Fukushima residents. The ultimate goal is to promote health and long-term health while having anxiety at the same time. So note that it is not for alleviating or eliminating anxiety.
調査の全体概要です。
This is the overview of FHMS.
まあ、大きく5つの調査から成り立ってい
It
ます。
consists of 5
基本的に
surveys.
つけているのは一番
The basic survey is the first component. We call it basic because it covers all the residents in the prefecture. And its primary goal is to assess the basic radiation exposure dose.
その上でですね、私たちは当時今もですが課題だと考えられている甲状腺検査
And other detailed surveys are thyroid examination, comprehensive health check, and mental health and lifestyle survey, and pregnancy and birth survey. There are 4 detailed surveys, and it has continued up to today.
報告の中でもあります。
The details will be reported in the following presentation, but let me give you the overview.
甲状腺がんの多発ということを
There were increasing number of children's thyroid cancer cases reported Chernobyl accident.
38
There were similar concerns raised for Fukushima, so we covered the all the residents who are around 18 years old or younger in TUE.
その避難者をせざるを得なかった人たちの健康を守るためにこの健康
Comprehensive health check coverage was residents of evacuation areas,
してますけれども実施
and the mental health and lifestyle survey was also conducted because they needed special attention as they are evacuated. And the last component is pregnancy and birth survey. There were some insensitive rumors that went around in Fukushima and all Japan. For example, the women in Fukushima should not give birth to babies. They have to expect increasing abnormalities.
まして福島の本当の姿をちゃんと知っていただきたいという
We wanted the general public to know the reality of the Fukushima prefecture. That's why we set up this component, and the details of these surveys will be given at a later timing. So let me give you the overview of each detailed survey. First, a basic survey. I'd like to emphasize here that 99.8% of Fukushima residents receive less than 5 millisievert of external radiation dose. The maximum value of external exposure is 25 millisievert, and if it exceeds 100 millisievert, you have to expect a health effect. But at this level, it is not at a level where health effect can be confirmed with statistical significance. This is one important point. Next, Thyroid Ultrasound Examination, or TUE, which covers 380,000 people who are young, 18-year-old or younger at the time of the disaster. And preliminary baseline survey covers all of them, and the full-scale or second-round survey is added when it is needed. It's important to note that these surveys have advantages and disadvantages. We have to inform the resident well enough for them to make an informed decision. We conduct surveys under their fully informed consent. We also promote understanding of disadvantages and advantages of thyroid ultrasound examination. This is some of the result. This is the average absorbed dose to the thyroid shown in milligray. This is the data of Fukushima children, and at the bottom you will see the data of the resident close to the Chernobyl nuclear plant. As you can see, the number is quite high in the Chernobyl accident-related location, and Fukushima's children's absorbed dose of the thyroid is order of magnitude smaller. We implement a variety of actions. I would not go into the detail, but here is some epidemiological studies that we have conducted. For example, nested case control survey, where we compare the dose effect relationship between the control group and the case group, and when we calculated odds ratio and correlate it with the dose, the relationship is not significantly different. With all these analyses, the Prefecture Oversight Committee has made decisions, a series of decisions, and now we've had the fourth round survey, and our official opinion is that no evidence of association between thyroid cancer and radiation exposure was found. To date, our confirmation is based on the latest data is that the radiation dose would not increase the detection of thyroid cancer. Children are quite sensitive, so we have to offer a support before and after the examination so that they can live life with peace of mind. And we are quite active in that front as well. Let me change the gear a bit. This comprehensive health check covers the resident in the 13 designated evacuation municipalities, about 210,000 people. One of the components is a comprehensive health check. This covers the resident from 0-year-old. Although the items to be checked might slightly different by age group. What we have identified is here, there are so many items that we have identified. For example, obesity has improved in age group 15 years or younger, but dyslipidemia persisted. However, there are some changes possibly from the changing lifestyle, which might add the risk factor of circulatory diseases. However, in general, no findings that indicate a radiation effect were found. Most of the impact is from the changing lifestyle, for example, eating habit and other lifestyle-related factors. But they should be paid attention to. That's why we offer support to the resident, for example, by leaflet and booklet and on-site seminars in response to the requests from the municipalities. And we offer individual consultation support too. This is about mental health and lifestyle survey or a KOKOKARA survey. Mental health is quite important, and also it covers lifestyle. So evaluation is done, and so that the people can get the result reflected in their lifestyle. It is a paper-based survey, and they can get the return from one by one. And it's residents are divided into 5 age groups, and this shows a K6 score, and this graph shows the percentage of those with a score of 13 points, and the national average is 3%. As you can see, right after the disaster, the percentage is quite high, suggesting the need for mental support.
ちなみに同じこの K6 っていうんですけども、この評価を岩手県、宮城県の被災区域でやったデータでは
When the same study was conducted in Iwate Prefecture and Miyagi Prefecture, the percentage was around 7. Fukushima's resident generally shows the need to receive mental care. This shows the breakdown by the resident mental health, whether they are in Fukushima or currently are located outside of Fukushima. Some of the people currently living outside of Fukushima might need mental support. This shows the children's and the emotion and the behavior status evaluated by their parents. The percentage of children who require mental support right after the disaster, quite a high percentage of children required care, but recently it has declined over time. But last year, the percentage went up. We are still assessing what was the cause of the increase, which gives us a still continuing challenge. These people are considered to be people with high risk, so we take high-risk approach for them, for example, by offering a telephone-based support. For the other general public, we take population approach. But they also have relatively small risk, so we will approach to the groups. The last detailed survey I'd like to talk about is pregnancy and birth survey. In the open session, Professor Fujimori will give you the details, so let me give you the overview. Every year, pregnant women in Fukushima will be registered with the maternal and child health handbook. And about 12,000 and 16,000 of pregnant women are covered in this pregnancy and birth survey. We used to use paper for this survey, and currently it is web-based too. Midwives and public health nurses and certified public psychologists also offer support, and which some of them will give you the presentation later. And this is what I'd like to emphasize most today in my presentation. Here you can see the percentage of preterm deliveries and low birth weight infant and congenital abnormality. We check this percentage for 10 years, starting right after the disaster. In any of these years, if the percentage is compared to the national average, what do you think? When Fukushima's percentage of these preterm deliveries, low birth weight infant, and congenital abnormalities, Fukushima's percentage is no higher than the national average. If we continued the survey, people might misunderstand we are continuing it because we suspect some abnormalities in the babies, so we decided not to continue. But it is true that continuing care is also important for the pregnant women. The percentage of mothers showing depression is on the rise, but we are continuing support to them. We are offering support, and it is important all the more for the time to be interactive, responding to their needs. Another thing I'd like to mention is this result. When we asked the people outside of Fukushima, people in Tokyo, about the radiation exposure's impact on the future generation of people's health in Fukushima, and about 30 people consider that there would be an impact in health. And this is, I regret, the misunderstanding has rooted in these people. So let me summarize. You are not really aware on where you live in Japan. But if you live in a certain place, it is important that if you can keep the dignity of your place of living. You might not have been aware of it until now, but we'd like to continue our effort to protect the dignity of people's place of living. Presentations might follow, and this is the end of my presentation. Thank you so much for your attention.
Dr. Yasumura, thank you very much for your passionate presentation.
Thank you, Professor Yasumura and Professor Oto. Now for our keynote lecture, Nuclear Disaster Medical Care and Response in Taiwan. It's a pleasure to introduce FMU Professor Shimabukuro Michio, whose biography appears on pages 15 and 16, showing that he brings national and international experience to Fukushima. Professor Shimabukuro.
皆さんこんにちは。福島県立医科大学の島
Hello everyone, my name is Shimabukuro with FMU. So I am going to facilitate keynote speeches. Please, we have Dr. Chen Min-tai from National Taiwan University Hospital. I'd like to introduce briefly about the biography of Dr. Chen. At Chusan Medical University, he has obtained a medical doctor license, and at emergency medicine at the National Taiwan University, he has gained a PhD for public health, and he has been working at the attending doctor at the National Taiwan University Hospital emergency room. Now he is the head of a center for emergency room. Especially as he has been playing a role to evaluate emergency medicine actions in Taiwan. And he has won an award, and he has been responsible for national activities in Taiwan since 1987. Nuclear power plant has been in operation, and he has a responsibility for the entire nation. And today, he is going to talk about nuclear disaster medical care and response in Taiwan.
I'd like to start this session. Dr. Chen Min-tai, can you start your lecture?
Thank you. Thank you for your kind introduction. Thank you very much. Okay. Good afternoon, ladies and gentlemen. It's truly a great honor for me to be here to have a little talk to introduce in Taiwan, the nuclear disaster medical care and response in Taiwan. But this time is not my first time in Fukushima, because maybe this is the 10th time, about 10 times to be here. Yes, I came here. The first time is 2012. 2012, just 1 year after the accident, the earthquake. Okay, so first I would like to express my deepest respect to the people of Fukushima. The event, the earthquake, the tsunami, and the nuclear accident of 2011 were devastating, but your resilience and effort in recovery has been remarkable, I think, from my point of view. So every time I come to Fukushima, I feel more and more comfortable and safe. And Fukushima momo, the peach, is very delicious. Yes. Okay, Taiwan had learned a great deal from Japan's experience and expertise in the nuclear disaster medical response. So many of our training program and response strategies have been shaped by the knowledge shared by the Japanese expertise. Today, I will introduce Taiwan's approach to nuclear disaster medical care and response, ensuring our effort in building a system to protect the public health in case of the emergency. Okay, and this is the content of my talk today. The first part is Taiwan's radiation emergency response system and medical network. The second part will be the radiation emergency medicine education, how Taiwan enhancing radiation emergency preparedness. And the last part, I want to show the effort from our pre-hospital care to national exercise of the nuclear disaster. Okay, maybe I should introduce my country at first before I dive into today's talk. So I think not everyone knows Taiwan. Where is Taiwan? Taiwan is just south of Japan. We are neighborhood, and the size of Taiwan is about 1/6 of Japan, and the population is also 1/6 as Japan. And we have not bad GDP. As you know, we produce many chips, semiconductor, and earn a lot of money from that. But I'm not do the IC war, so I cannot earn that many of money. And our capital is Taipei City. And this picture shows the density of our population. So our population will concentrate in the north, central, and south. And it's a risk. Our nuclear power plant is here and here. So there was a very high risk if something get wrong. Okay, and the first part is our radiation emergency response, and I also introduce our medical network. This is like your NRA, the Central Regulating Authority of Radiation Disaster in Taiwan is NSC, the Nuclear Safety Commission. And the NSC, maybe you will know, it's AEC before, Atomic Energy Council, but it just changed his name 2 years ago because it is just downgrade. But the mission of NSC is the same. They try to develop and enforce the regulations and add to conduct research and development of nuclear technology. And in Taiwan, we have defined 5 categories of radiation emergency. One is the nuclear power plant accident. A second is the cross-border nuclear emergency and radioactive material accident, transportation of nuclear material accidents, and radiological disposable device accidents. So not only the MPP accident. And this is the side of our MPP. We have 4 MPP, but one is never finished because maybe some political issue and maybe some technological issue. So we have only 6 nuclear reactor operation, but the MPP1 is decommissioned several years ago, and MPP2 also decommissioned. And the MPP3, only 1 nuclear reactor is now still operation. And about 2 or 3 months later, it will start to be decommissioned. So maybe the end of the year, in Taiwan, there are no operating nuclear reactor. But it's not the final result because our political issue is still someone wants to extend the license of the MPP3. Okay, if the reactor is still operation, if something bad happen, this is my nightmare because our hospitals is too close to the MPP, and within 5 kilometers. We have 4 hospitals. Taiwan's hospital is very crowded, and many patients admit in the hospital. And it is very, very difficult to do the evacuation things. We had a discuss yesterday. So if the nuclear disaster occurred, what should this hospital do? To flee or fight, stay or go? It's a big problem. But after our reactor had decommissioned or shut down, maybe anything is become happy end? No, because we have another risk. This is an accident 43 years ago. It is an accident. It's also a radiation accident, but beyond the nuclear power plant. In the 1982, we have an accident about related to the radioactive material, the cobalt-60. It was found in the import scrap metal, and which has been used to produce construction materials. So you can see this house, and there are some word on it. I can translate. It said Minshan Village House, and it is radiation. It's radiation contamination, and it's here. So beware of the radiation hazard. This is not in the rural area. It's just near my home. And there's a Bentong rice box shop there. I can go there and ride my bicycle to buy the rice box. But initially, when I buy my house, I have some radio detector and try to detect my house. It's okay. It's okay, yes. But it has some impact. 1,669 housing units were identified as contamination, and 98 units exceed radiation level of 15 millisievert per year. And what's our government response? Our government take the affected unit underwent demolition or get them to improvement or just left them vacant. And they conduct nationwide inspect and reinforces the regulation on the scrap metal import follows. And what about the health of the resident in that house? In 2015, we have a report from our government. There are more than 32,000 people involved in this accident, and 420 people exceed 100 millisievert. 43 years ago, and what's the result? The result is a little high risk of leukemia, but no, not detailed like you, because it's 43 years ago's data. And after 2002, some patients that get decreased white blood cell, platelet, and RBC recovered 20 years later. And there's no clue to relate it to the other cancer, only leukemia. And this kind, but we're still working on the health examination of these patients, and the psychological and social impact, including stigma and anxiety, was still significant. So this like the Fukushima's condition. So where is the risk? This is a map about the vulnerable areas of radiation hazard. You can see the red area here. This is Yunlin County, and this is Kaohsiung City, the Takao. In the red area, there's more than 11 facilities related. They have category 1 or 2, extremely dangerous source or very dangerous source. So in these areas, we are nuclear power plant here and here, but not the dangerous is not only in the nuclear power plant. So we need to prepare. And this is about our emergency hospital network. We have 3 levels, not for the radiation, but for the emergency. Our emergency responsibility hospital system is since 2009, and last year we have and this year we have 205 hospitals. We have 3 levels. One is the basic, 79 hospitals, and 74 intermediate, and 52 advanced. The advanced hospital is very big, and they can do nearly everything you want for the resuscitation. And in the intermediate, the emergency response hospital is just it can do some operation and can admission, and it's okay for the general emergencies. And we had a connection of these three labels, so we have a 14 emergency referral network for patient transfer. This is the radiation injury emergency response hospitals. We only have 19, only 19. And you can see we only this nuclear emergency hospital just north and south, because it's just prepared for the MPP. But according to the hazard map, there is also some dangerous source, so it's not so, actually it's not so functional if we don't have MPP threat. So the level 1 is in the MPP, and level 2 is the hospital near the MPP, and the level 3 is the medical center. Okay. Above this emergency hospital, we have 6 regional emergency medical operation centers. I come from this one. This is the Taipei area. We have several cities and counties: Taipei City, New Taipei City, Yilan County, and I'm the director of this. But the EMOC, regional EMOC, is under our Ministry of Health and Welfare. But it's not a government unit. It's just entrusted by the hospital. So I'm from the hospital. I am not an officer. So this EMOC cannot command. It just do the coordination. And the really commander in the disaster is the central EOC. If something bad happens, our officer will enter the CEOC, and our EMOC will support and coordinate the data to the CEOC to help them. So this is the first part, the network. And the second, I would like to talk about the radiation disaster medical personnel training. This is my job, one of my jobs. I will show you how we enhance our radiation emergency preparedness in Taiwan. About 20 years ago, just after SARS, my teacher, Dr. Fu Yuanxi, have a small-scale survey in my hospital. And we asked 2 questions. Question 1, do you feel that your ability are sufficient to respond to various disasters? But the lowest one is what is the radiation? And the second question is, what's your willingness to support in the various disasters? The lowest is also the radiation. So the key, they don't want to help, and they feel they don't have that ability. And the key concern is the fear of public panic and perceived inability to manage radiation incident, especially compared to biological or chemical. And this morning, I see the Dr. Hasegawa's survey in Japan. The lowest one is the biological, so it's not the same as Taiwan. So just impact, it is the lower interest among medical personnel in learning radiation emergency medicine. No one wants to learn this. And thank you for the Japanese teacher. I have the opportunity to go to Japan to learn the radiation preparedness and medicine in 2007. At that time, I'm a young doctor, just completing my training to be an emergency physician. And maybe there are someone you can familiar here. And this is me, he's so young, and we'll go to the National Institute of Radiation Science. It's a happy time. We have the 3 days course, and we discuss the Tokai-Muna nuclear accident at that time. And everyone is happy. And we'll come back to Taiwan, nothing I need to do because we don't have that accident. But things change. Originally, the Taiwanese government, public, and medical community did not place much emphasis on radiation emergency medicine. But after 311, after 2011, there was a significant shift in the attitude. Everybody think it is a issue, a very important issue. Before I go to Japan, before 2011, in the course we have good professors on the deck, but the student is only 6. But after the 2011, same professor, and the student is 306. Yes, just it's different. Everything makes different. So we reconsider the challenges and opportunities in Taiwan's radiological in emergency medicine education. Years ago, we found we have resources and infrastructure challenges like our such as limited stores and fundings, outdated equipment, insufficient institute support, regulation gaps, policy development barriers. We also find that we need to improve our collaboration and some engagement. We also need to improve our education and increase awareness to heal the awareness gaps. Okay, what we do? We go to Japan. We learn from you. So, Kojo Sensei, you're here. Yes, since 2012. I'm here, and I think there are some friends and some experts here. And the second one, but I'm not put every photos I come here on this because I'm come here very many times, and I need to point this guy. This guy is our vice minister of Ministry of Interior. He also had concern of the nuclear disaster, so now he become a true officer. I think this is a good connection for us and the government. Okay, so we also go to not only Japan, we also go to Russia because they have Chernobyl accidents. We need to know the worst scenario. Maybe your scenario is not the worst. No one died due to the nuclear disaster. Yeah, but they do. And I learned the burn patient of radiation is the most critical there. And I learned how to treat that patients in Russia. And then I received 3 times of the training from the Americans. They go to Taiwan and set 3 symposiums, 3 training courses to train us to have that preparedness for radiation emergency. And after that, I frequently visit Japan and United States. But in Fukushima again and again. I'm sorry, this is 2018 for NIS again. I led my young colleague to go to NIS for further training, and I go to the Harvard. And I also had a visit in Nagasaki and Saga, and Hirosaki and Hiroshima. So nearly everywhere in Japan, and I learned very, very much. And after this prepared, I just organized the new edition of a radiation emergency and medical training course for Taiwanese medical personnel. But at that time, that is COVID. So I do the online training course. But the online training, it have many levels, like basic and advanced, and many topics, but the effect is not so good. So I also do the hand-on training course after the online training course to test if they learned or not. Okay, this is the example of our hand-on REM training course in my branch in Jinshan. The Jinshan Hospital is near the MPP, so they have some insight to learn. And we invite the superintendents of the branch, and we do the small group teaching for decontamination to transportation and to treat the patient. And we train the sick teachers. we use air mannequin, and they put on the training isotope thorium-232 to let them know that they can detect the radiation. They let them feel the radiation. I think the effect is good if they do just in reality to check the radiation. Okay, this is my final part. I think I should introduce the Taiwanese radiation medical response framework from pre-hospital care to the nation exercise. It's just a link. In my concept, I want to just link this one from the side to the central government. So I joined the group to edit this menu. It's the menu for the first responders. They set the rules, like how do you put on your PPE, and how do you detect and make anything standardized, have standardization procedures. And we also tell them how to do the zoning according to the radiation dose, and how they can divide in the hot area, warm area, and cold area as seen. And we train them to do the on-site medical activities, like you should do triage the patient and some resuscitation treatment on site, and then transport to the hospitals. And in the hospitals, we follow the REACT-TS protocol. We divide it in 8 steps: activation and notification, and inform synthesis, and ED prepare, and patient proceed treatment, decontamination, patient decontamination, and clean up. Okay. This is one example in my hospital. If no one tells us one patient with radioactive contamination will come, in my hospital, what will you do? Okay, in my hospital, it's the level 3. So this is my hospital. It's very big. It's over 2,080 beds, and a lot of ED patients. But here you can see the triage, just nearby the triage nurse, there's what's here? It's a radiation detector. So if the patients sit there and they have the radiological contamination, it will alarm. And it work. After it alarm, what do you think the next step will the nurse do? They will call me. Dr. Chen, something wrong. Please come here. Anytime. But I train a lot of residents, doctors, and then they will tell the residents first, and they will get another equipment to check. And it did alarm several times, because some patients have just received thorium 201 examination, and they carried the radiation, but no one is from the MPP contamination. So I think it's work. And then we activate a notification after we receive that report. And we need to clarify who activate our EOP, and who is notified by whom, and where, when, and how to report in. And we assign the position and function. We will set up our HICS, Hospital Incident Command System. And then we will have, if the telephone is still on, we will use the checklist to get what? To get the information, because the information on scene is most important for our decision. And then we do the ED preparation. We prepare our receiving area. We will put some clothes on the plastic clothes on our just in front of our ED decontamination room, and we'll mobilize our staff to put on their PPE and turn on our equipment. And also, we will control the room, and we have some posts on there, because not put on PPE is not every day's work. So maybe they will have some problem to put on their PPE. Okay, then if the patient arrive, we will proceed triage. The first is medical triage, because the medical is the first. We need to stabilize the patient first. Then is the radiological triage. We need to check their contamination or not. If they are not contaminated, he or she should be treated as a normal patient, but we need to follow them. So we do the identification, history taking, physical examination, and other tests. The most important is the psychological support. I had told to my staff that the risk to the hospital staff is minimal in a radiological event. And then we will manage life-threatening problem. In the emergency medicine is from A, B, C, D, E. The A is airway, B is breathing, C is circulation, D is disability and exposure. If someone had problem about the radiation, what's the level? Maybe it's the level E. So you need to solve the first A, B, C, D problem. Then we do the contamination assessment and remove patient's clothes and shoes carefully. And we had a SOP to get their clothes off. We also have SOP for wound and skin cleaning. And we also have SOP for the sample collection from their nose and their oral cavity. Okay, then we do the wound care, and we also check their isotope to give them the chelating agent. And we also follow this one, the radiation emergency management, the protocol from the Americans. And then we will check the clean up and recovery step, and we will have double bag contamination clothes to let them get in and remove the waste from the decontamination room every 20 or 30 minutes and put in a handle area and transfer to the lab for analysis and follow our nation's regulations. We have annually, because it's not a frequent accident, so we have annually radiation emergency drill in the hospitals. We have a fixed assessment tools and assessment model. We will check the emergency response plan just before the drills, and we have a standard evaluation format, and we have at least four members to evaluation. The one is the specialist from the nuclear medicine. He will check the decontamination procedure and the further management of the radiation. And the second one is the man from the emergency medicine, like me. He will check the emergency medicine and hospital emergency response procedures is correct or not. It's not according to their response plan or not. And the other one is the NSC officer. They will check the radiation protect regulation and radiation detect technology. And the last one is the most important, is the health officer from the health bureau to let them know their hospital do good or wrong. So we will have this one, standard evaluation form. You can see that we're under the evaluation, and this is the specialist from nuclear medicine. We have a form, and they can put a score on it, and you will say the good, pass, failure, or not available. And we will calculate the score. If they act good, we will have an award to the hospital and thank you for collaboration. You can keep your level. And if they do, how about if they are not functional? We will have arranged some training by myself to help them to improve their action. And then we walk outside from the hospitals. I joined another group to improve the local government radiation preparedness and rescue training. I joined that project about 2 years. This project had managed many training to the participants, including the police department, the environmental protect agency, fire department, health department, and the NSC. We will have some course to tell them that the speech to lecture. And in the afternoon, we will have a web-based tabletop exercise. And this is on the web, so we can check every step of every stakeholder, and we will discuss and review their step, right or wrong, or need to find more questions to solve. And after the training, some hospital might be help to cooperate in this project, and the Jiayi Changgen Memorial Hospital just do emergency drills related to transport radiation material accident as the same scenario we do in the local government. In the central, we have the National Nuclear Emergency Exercise. 2 years ago, I was invited to the committee as an evaluator. And the focus of the 2023 is preparedness for complex disaster and nuclear accidents, including the scenario inspired by the Ukraine-Russian conflict. And the object is validate our facilities' emergency self-defense ability and demonstrate the response capability. And last year, the scenario changed because most of our nuclear power plant is decommissioned. So the scenario is the nuclear accident during the MPP-1 decommission, including some response under military threat. So our focus area is spent fuel pool cooling, backup communication system, and radiation injury rescue. They are not doing so good, but I make my voice. We get more prepared, including Prison Blue, and try to get the DDPA and try to improve the act as seen. They didn't do well later. I'm here. Okay, the last one is the conclusion. To summarize, Taiwan has developed a structured and coordinated approach to the nuclear disaster medical care. First, our integrated system ensures that different agencies from hospital to emergency responders and government departments work together effectively. This cooperation is essential to a strong and efficient radiation emergency response. Second, the education innovation has been the key. Taiwan has greatly benefited from international partnership, especially with Japan, United States, and other countries. This collaboration has helped us refine our training programs and continuously improve our preparedness. And finally, our response framework is comprehensive, covering everything from pre-hospital, emergency care, to a large-scale nation exercise. By the integrated real-world drills and systemic training, we aim to ensure a strong and sustainable response system. With continuous learning, collaboration, and preparedness, we strive to protect our public health safety in the face of potential radiation emergency. Very much. ご清聴ありがとうございました。
はい、チェン先生ありがとうございました。日
本の Thank you so much. So nuclear disaster in Japan. Yeah, you said that you have learned a lot from our experience, but your scale is larger than Japan already. You have a disaster control system. It was quite impressive to hear your presentation. We have questions that we got in advance.
Received several questions in advance, so can you answer to several questions?
Yes, sure.
Okay, so first, 日本語で。
I will switch to Japanese to get ready for the disaster. International collaboration is important. What's your view on that?
I think the most important is information. The information. Taiwan have very few actual radiation emergency events, and we don't have enough budget and our research is limited. So international cooperation is very important for us. We hope to focus on two key areas. The one is sharing the real case experience. And the two is the innovation in the radiation disaster medical science, like this time. I involved into the symposium yesterday to today. I can understand some Japanese, so I learned a lot. I think it's a very good model, and please invite our expert to here to join this symposium. Thank you.
Okay, thank you. So second question is, チェン・ミンタイ先生は救命救急がご専門。
Doctor, you are specialized in the emergency, but radiation medicine is also the area of your interest. What triggered you to make to become interested?
Emergency medicine, but what made you interested in radiology, which at first glance seems to be outside your field of experience?
Yeah. So someone asked me before. So in Taiwan, the disaster medicine is a part of emergency medicine. Yes, and the radiation emergency is one part, is a subfield of disaster medicine. So maybe I need to learn this because it's not everyone have familiar with this. So I have the opportunity, just as I said, in 2007, I go to NIRS. But initially, I just want to go to Japan for fun.
But so, not only you, the other guys in emergency medicine, interested in the radiation medicine?
Yes, but not much. Not so many.
Okay.
Yeah, but someone should do that. So I will just invite my colleague, Dr. Chen here, to hear and to join the symposium to learn more. He's just 10 years younger than me. I think it's very important for the next generation.
So, third question. Taiwan ならではの被爆医療備え。
So, yeah, do you have any readiness which are unique to Taiwan?
Any medical care or preparation that is unique to Taiwan? I would like to know about it.
You see the exposure?
Yes.
Exposure medicine in Taiwan?
Yes. Medical care and preparation.
Yes. We have the night. I just introduced the 90 hospitals in Taiwan for the radiation, for the nuclear disaster. And in Taipei, the Taipei Veterans General Hospital have a connection with the MPP and MP1, MPP2. And in Kaohsiung, there's one, the Kaohsiung Medical University Hospital have a connection of MPP3. So there are the two hospitals have the most expert and equipment to treat the radiation exposed.
Okay, I'm not so familiar with in world situation, but it looks to me the preparedness is most advanced in Taiwan. Is it right or not?
I think it's not enough.
Advanced.
Yeah.
Okay.
Yes.
I think so. So final question is. 台湾には徴兵制度があると伺っていますが。
In Taiwan, there is a draft system. Oh, sorry. As a preparedness. And is there any education?
There is a conscription system in Taiwan. But is there any education on radiation protection for those who are subject to conscription as a precaution against the radiation emergency?
For the military guys?
Yes.
軍の人たち。
I want to say I'm over 20 years ago, I'm a Navy second lieutenant. Yeah, but every Taiwanese, the male, only male, need to go to the army military service. So I just pick something, and I need to be a Navy Ekimae, or the second lieutenant. I'm serving a battleship, and at that time, I know we need to have the NBC nuclear, biological, and chemical training for this trade. but I'm still in the reserve force, but not active service now. But as I know, yes, they do have their MBC course. But I think it is very fundamental, not so like this, not so many things to have the detail. So I think that yes.
Okay, so we'll close this session. So thank you very much for your wonderful lecture. それではチェン・ミンタイ先生のセッション。
So this is the end of the Dr. Chen Mintai's presentation. Thank you very much.
Now it's time to restart. Session 1, Linking Achievement of Fukushima Health Management Survey Across Generations. Dr. Horikoshi Naoko cannot join today as the chair. The session will be chaired by Dr. Shimura Hiroki, Vice Director, Radiation Medical Science Center for FHMS, and Dr. Maeda Masaharu, Director of the Department of Health Survey and Personal Support.
Chaired by Professors Shimura and Maeda, whose biographies in the program show extensive commitment to academic health care and the quality of life in Fukushima. Chairs, go ahead.
はい、それでは福島医大志村から開始させていただきたいと思います。最初の演題は、福島県
I, Shimura, would like to open the session. The first presentation will be made by Professor Suzuki Satoshi. His academic achievement is detailed in the program. He is a surgeon, but he is also a specialist of thyroid medicine. Professor Suzuki, over to you. Thank you. Thank you for your introduction. My name is Suzuki. My presentation is the current status and the future of thyroid ultrasound examination. There is no COI. At the center, we cover the primary examination and image diagnosis. The first topic I'd like to cover is the current status of TUE and the past findings and the future of the UE. There are some questions raised by the participant of the examination, so I'd like to cover them. There are some findings based on the latest data gathered through TUE, so I'd like to talk about that. The final component, number 3, feature of the TUE. I will talk about our future challenges as well. First, about the TUE. This is the flow of TUE program. A resident is recommended to have a primary examination where ultrasound examination is conducted for a nodule and cyst. If there is no nodule or cyst, the person will receive grade A1 and will wait for the next examination. If there is a cyst or a nodule, depending on the size, grade changes. If a cyst is smaller than 20.0 millimeter and a nodule smaller than 5.0 millimeters, they will ask to wait for the next examination. But if the cyst and the nodule are bigger than that, they will recommended to have confirmatory examination, where they will receive a consultation from a doctor and a detailed TUE survey and urine and blood test. Certain number of residents might confirm that the cysts and the nodules are not as conspicuous or smaller than we initially thought, then they will be recommended to sit for the next examination. If it's not A1, grade A1 or grade 2, depending on the eligibility for the cytology, that it would take a different course. If cytology criteria is not, they will ask to sit in the next examination. If cytology criteria is met, they will receive medical treatment and will be recommended to have a follow-up at clinic. If after the cytology, if no medical treatment is required or no follow-up at the clinic, they will wait for the next examination. Steps to take the primary examination. Basically, the venues are twofold: schools or medical institutions or public facilities. If the resident is studying at a school in Fukushima, they will take examination in the school. If they are not, then they will have that examination at the medical institutions or public facilities. First, we arrange the venue and create a schedule for the examination. Once it is finalized, we will send notifications to the eligible residents. And here you can, in the enclosed, you will have the notification and the advantage and disadvantages of the examination. They and their parents read it and make a decision as to whether to have the test and submit the notification. When the day comes at the school, they will take the examination. But if they decide to take it at a medical institution or public facilities, they have to confirm the date with the return slips. The result will be mailed to them individually, and the same is also true for medical institutions. Diagnostic criteria. If a cyst is greater than 5.1 millimeter, or if the cyst is greater than 20.1 millimeters, or a cyst greater than 5 millimeters, then the grade is B. I am quite often asked if it's okay to just keep monitoring A2 grade nodules and cyst. Cyst is something like a capsule with liquid in it, and it's unlikely that it turns into a cancer. And also for the cyst, if it's smaller than that threshold, it is unlikely to cause a cancer. And then people seem to be convinced with that explanation. But for A2, it is different. So let me show you some data. This is the frequency by age group of latent thyroid carcinoma. Latent thyroid carcinoma is the kind of cancer that have gone undiagnosed during the lifetime of the person. As you can see in the graph, the percentage of latent cancers detection rate goes up as age. You might be surprised to find how frequent they are. But if you look at the latent cancer more closely, and this graph shows the percentage versus the tumor size, and quite a large number of them is so small that you need a magnifier to see it. And from this, we can say that such latent cancer is unlikely to cause health effect. This is a guidebook for diagnosis and management from Japan Association of Breast and Thyroid Sonology. For a cyst smaller than 5.1 millimeters, smaller than 5.0 millimeters, they will be put to follow-up. So we will put them for follow-up. If nodule is 5.1, is between 5.1 and 10.0 millimeters and is strongly suspected of malignancy, fine needle aspiration cytology is performed. And if it's greater than 10.1 millimeters and smaller than 20.0 millimeters and suspected of malignancy, it will be still followed up. And if it's greater than 20.1 millimeters, it will be put for FNAC. The scale of TUE keeps expanding, so it was almost impossible to continue with us own. That's why we have expanded the cooperative medical institutions. And in total, we have received a cooperation of 3,467 medical professionals all throughout Japan. We feel the need to nurture the professionals in thyroid medicine who can perform examinations. That's why we launched the Fukushima Joint Committee for supporting TUE. We got the support from Thyroid Medical Association, and participants are members of Fukushima Prefectural Medical Associations and physicians and medical technologists who work in the prefecture. And our main tasks are giving instructions and workshops and creating test questions for qualification examinations. This graph shows the number of cooperating medical institutions over time. During the pandemic, there was a slight decline, but we have so far successfully managed the number of such institutions. Their locations in the map. Aizu and Kennam have less numbers. They are also tied up with other tasks. Some of the cooperating medical institutions had to stop the operation of TUE. For these areas that we do not have enough number of medical institutions, we make an effort by setting up public examination venue to ensure opportunities for the residents. About half of the eligible residents become adult, and some of them leave the prefecture. This map shows the cooperating medical institutions commissioning the thyroid ultrasound examination outside the prefecture as of November 1st, 2024. Eligible resident, a Fukushima past resident, can have the examination in whatever the prefecture they are in. We started these initiatives in 2011, and now we have concluded its sixth round examinations. And in parallel, we have conducted a survey at age 25 and 30. We are now starting the seventh round examination. We are eager to continue this initiative with your support. Next, past findings of TUE. This is the summary of TUE result as of June 30th, 2024. Sorry for the busy chart. Participation rate of the primary exam for the participation rate has declined year on year. The number of malignant or suspected for malignancy number is as shown in the table. Pathological diagnosis of the surgeries are as shown. Most of them are papillary carcinoma, which you might be familiar with your clinical practice. This table shows estimated absorbed thyroid doses and the malignant or suspected malignancy detection rate in the full-scale survey, which is a cumulative total of the second to fourth round surveys. Here, the radiation dose has been broken down into 4 groups. We have also adjusted the analysis by sex and age. At the top graph, if you look at the odds ratio of thyroid equivalent dose and detection rate, there is no clinically significant difference. If we further adjust the analysis with survey intervals, there is no significant correlation between the detection rate and the thyroid equivalent dose. Based on this result, the opinion for us is that there is no association between the detection rate of thyroid cancer and radiation exposure. Those was found from the preliminary baseline survey to the fourth round full-scale survey. But we are conducting other types of analysis, and this graph is used in the 23rd meeting of Prefecture Subcommittee for the TUE program, showing the cumulative detection rate of malignancy and suspected malignancy. The horizontal axis shows the years of observation since the earthquake, and the vertical axis shows the detection rate, and doses lower than 3 millisieverts is the solid line, and the dotted line shows doses are smaller than from 3 to 10 millisieverts. And there was no clinically significant correlation between the detection rate and equivalent dose. And on the right, we performed the same analysis, including the cancer cases in the registry. And again, there was no significant correlation between the detection rate and estimated dose. There are other findings other than carcinoma, for example. This shows an age and sex-dependent detection rate and the sizes of thyroid cyst in preliminary baseline survey. Left is male and right is female. Detection rate of cyst goes up in early teens, and it goes over 10% at 12. And so about half of them will receive A2 score. And compared to male, female has higher percentage. But if you look more closely, blue means that cyst is smaller than 3.0 millimeters. Of them are relatively small. We will keep you informed with this type of data. Last component, future of the TUE. Future focus 1. First, it's important to keep improving the examination environment. We have to enhance the convenience for the eligible resident. We plan to implement a web-based reservation system where people can complete reservation end-to-end online. As the number of residents leave Fukushima, we have to enhance the number of hospitals outside of the Fukushima prefecture who can perform examinations. Also, we might need to add public examination venues which are open in evenings and after hours. More importantly, it's important to keep residents informed of advantages and disadvantages of TUE. They have to be fully informed before making a decision. It's solely their decision whether or not to sit for the test. This is a result of a Fukushima Prefecture's questionnaire survey. This is for participants between age 16 to 17 and the participant and younger than 18 and parents. Yellow means that they've already known the advantage and disadvantages. Fortunately, about 50% of the parents knows them, and if it's for the participants, it's around 30 to 40%. We had another round of survey after they've read the explanation, how they find it, how they think of it, what they think of it, and is it easy to understand. And about half of people think that it is easy or rather easy to understand, so it might be important to let them read the instructions and explanation. Future focus too. It's important to enhance the supporting activities. In some examination venue, we will give them a preliminary result to alleviate their psychological burden. In the confirmatory examination venue, nurses and clinical psychologists are made available to alleviate their mental pressure. Medical consultation line is also available. They can get a consultation by medical doctors. On-site lectures and sessions. We have so far conducted about 300 times of these lectures and sessions, and we will continue that. We also offer support to the medical expenses that is required after the TUE. One of the new initiatives is Sai Cafe, which offers peer support for the resident diagnosed with thyroid cancer to ensure peace of mind in them. Thank you for your attention. Thank you, Dr. Suzuki. We will take your questions at the end of this session 1.
Thank you. This is Maeda speaking. I'm chair. Let me introduce next presenter at our center. Dr. Oikawa Yuichi at our center. For his background or profile, would you please refer to the program? Dr. Oikawa has been supporting the telephone consulting service ever since the foundation of our center. He's the head of this service. And today he is going to talk about the influence of COVID-19. Thank you for the introduction. And Mental Health and Lifestyle Survey, or MHLS. I am responsible for this. My name is Oikawa, and I will talk about the influence of COVID-19 on KOKOKARA Survey, or MHLS Survey, and also the telephone outreach support we offer. This is COI disclosure. Today's topics, as is shown on the slide, there are 3 topics that I'm going to cover. So without further ado, let's start with the first topic. So first is about MHLS and also outreach telephone services, telephone support. This is the objective of the survey. So through the survey, we aim to gain a long-term understanding of the mental health and lifestyle issues with individuals affected by the disaster. Based on the health information we gather, we aim to provide appropriate support related to health, medical care, and welfare that is tailored to each individual, specifically through outreach telephone support. The survey covers about 10,000 residents in the 13 municipalities shown in pink color, which has been designated by the government as evacuation areas. The only city shown in blue, which is Date City, is not the entire city, but the part of the city is included in the survey. The questionnaire is divided into 5 groups according to age, and the survey form is sent by post to each individual, not to families. Next, I'd like to talk about outreach telephone support. We select people to support based on the results of our surveys, and then rather than waiting for calls like the Inochi no Denwa lifeline hotline, we make outreach calls to provide support from our side to the people affected. The support team is made up of a variety of different professionals, including certified psychotherapists, public health nurses, and social workers, and we assess the mental and physical health of the individuals affected by the disaster, as well as their living conditions and whether or not they are already receiving some kind of support, and provide health information, recommended medical checkups, or if necessary, connect them to local resources or medical institutions. To date, we have provided telephone support to around 40,000 people already. So about the outreach and telephone support, there is a strength. Those strengths are because we go to people regardless of whether they want to seek advice or not, we can approach them, approach the people who are unable to seek help themselves. Also, because we understand the situation from the survey beforehand, we can approach the essential issues at earlier stage, and we can provide rapid support to people in remote areas without being affected by geographical issues such as the time it takes to travel or the cost of transportation. I covered MHLS so far, but from here onwards, I want to focus on the result of MHLS survey from the COVID-19 perspective, the influence by the pandemic. So as we continued MHLS survey after the earthquake from the end of 2019, the COVID-19 spread worldwide. According to data from April 2023, the total number of infected people worldwide was about 760 million, and the cumulative death toll was as high as 6.91 million. In Japan, after the first case of infection was confirmed on January 15, 2020, in order to prevent the spread of infection, schools were closed, large events were cancelled, and people were urged to refrain from traveling between prefectures and were forced to stay at home. The number of new positive cases in Japan was particularly high from July to September 2022, so-called seventh wave, and there were about 1.48 million new positive cases of COVID-19. So because of the COVID-19 pandemic, what kind of change was imposed on us, especially our lifestyle had to be changed. And also, important mental health issue occurred as well. For example, anxieties or concerns if myself will be infected by the virus or my family, because of the activity restrictions due to the pandemic, there are people who are isolated. And also after being infected by COVID, people were struggled from the reputation by the people around them. I think these are unique issues with COVID-19. So the impact on the mental health by COVID-19 has been reported worldwide. For example, the impact of school being shut down and also the quarantine has been impacted the psychology, the mental state of parents and also children, and also existing social problems became worse, and also there was a health impact due to the change in their lifestyle. So this kind of a pandemic can give a negative impact on our physical and also mental health. Then, what was the impact on the people who were affected by the disaster? Now I want to share the result of the survey. So we added questions about COVID-19 to our survey in 2020, and which is reflected to this graph as a number of cases. So I think if we can compare our survey result and this graph, it will be easier for you to understand. So COVID pandemic started. However, there weren't so many people who were infected by the virus in 2020, and also the FY 2023 survey was conducted when the COVID-19 cases were on the rise, and in FY 2022 survey was conducted when restrictions on people's activities were relaxed, but the number of new cases increased rapidly. In this slide onwards, I want to focus on the result of our survey. So this page shows the percentage of people with drinking problems. The percentage differs between men and women, so we will look at it by gender. Dark orange color shows the data after FY 2020. So since 2020, the number of both men and women have been declining year by year, even under the pandemic. In other words, the drinking problems did not become worse under the COVID-19. Next is the percentage of individuals with high risk scores who are likely to have general mental health problems such as depression and anxiety. Compared to the 3% high risk rate in surveys of the general population that was unaffected by the disaster, the rate was higher immediately after the earthquake at 14.6%, and while it was gradually improving in 2020 and 2021, the rate increased again, and in 2022 it decreased slightly. Under the pandemic, the ratio of people with mental health increased slightly, but it did not become significantly worse compared to the earthquake. That was our finding. So what about if we look at this by age group? The proportion of individuals with high-risk scores aged 16 to 39 increased over time. But the older age group, the lower the impact, especially among the elderly. Next, here's the percentage of individuals with high K6 scores by gender. As a general trend, the percentage of individuals with high K6 score was higher among women than men, and this trend continued even during the pandemic. The next question was about whether people felt that their lives have been affected by the pandemic. When we looked at the results by age group, we found that the proportion of people aged 16 to 39 were less impacted compared to the other age groups. In addition, more than half of the respondents did not feel that their lives have been affected, and such percentage increased year over year. However, we compared the ratio of individuals with high K6 scores in a group of people who did not feel the impact and the ones who did. There was a big difference. The percentage of individuals with high K6 scores was higher, and it kept expanding year over year in the group of people who were feeling that their lives have been impacted by the pandemic. It is estimated that there is a relationship between the impact of the pandemic on people's lives and their general mental health. The final part of the survey results focus on whether or not the people have anyone to consult with. Compared to FY 2010, the results for 2021 and 22 show that the percentage of people with no one that they can consult with has increased. With the spread of COVID-19, the percentage of people with no one to seek for advice increased. So far, I focused on the result of a survey. I want to share with you the long-term perspective and how we are going to monitor this going forward. So what could be the reasons for these results? Polarization of mental health, that's the first point I want to focus on. A study by Kobayashi et al., focusing on workers in Fukushima Prefecture, reported concerns that workers' psychological distress has significantly worsened since pre-COVID. MHLS also showed that the proportion of individuals with high-risk scores was higher among young people and women. The percentage of high-risk individuals increased during COVID-19, but it was not approaching the level seen during the earthquake disaster. The mental health of people who feel that COVID-19 has had an impact on their daily living has worsened. As it is also possible that there is a growing polarization between those who recover and those whose mental health continues to deteriorate. So, what are the factors that cause this polarization? We'd like to focus on the acquisition of resilience based on the previous research. According to a 2021 paper reported by Murakami et al. From Fukushima Medical University, the general mental health of the population did not decline after the declaration of a state of emergency, although this was based on the data up to May 21st, 2020, and the paper cited the fact that the people affected by the disaster had already acquired resilience as a factor. However, on the other hand, it was also reported that the absence of a person that they can consult with was related to a decline in general mental health. So I'd like to share the real voices of affected people that were gathered through our telephone outreach support program. So these are the actual voices we received from the people affected by the pandemic during COVID. The first comment was, like immediately after the earthquake, I feel depressed because I cannot go outside, but I go shopping and take walks while being careful not to catch any infections. And also, I cannot meet with my friends in person, but I am trying to maintain the connections with them since the earthquake by phones and other communication methods. And also that I'm trying to remember the guidance I received from public health nurses during the earthquake, such as chewing my food well, starting with the vegetables, and I'm trying to do that even during the pandemic. So there were responses that showed people were putting into practice the experiences they had learned from the earthquake even during the pandemic. On the other hand, we heard following voices too. And because I was afraid of infection by the virus, I stopped going to the hospital for regular checkups, or because community group activities were cancelled, I had few opportunities to talk with my friends. There were also comments from telephone support about the decrease in resilience and use of consultation resources. So such support is important based on these results as well. In particular, the result of a survey to date have shown a link between not having someone to consult with and low general mental health, not just during the pandemic. So it is thought that continued attention is needed even post-COVID, when the number of people without a person to consult with has increased. The outreach telephone support we are providing is very important to continue, as it provides information on necessary resources and someone to consult with. Finally, here's a summary. The result of the survey conducted during COVID-19 showed that the proportion of individuals with high-risk scores had increased compared to the pre-pandemic. However, the increase was not so large. One possible reason for the limited increase in the proportion of individuals with high-risk scores is that many of the people affected by March 11 had already gained resilience from their experiences. The proportion of people with high-risk scores who feel their lives are being affected is increasing, which may be leading to a growing polarization because those who are recovering and those who remain in an unhealthy state. The percentage of people who have no one to seek advice from is increasing. Since lack of someone to seek advice from is related to a decline in overall mental health, attention will be needed also in the future. For this reason, it is meaningful to continue our outreach telephone support. No one can predict what disasters or problems will occur in the future. I think that continuing to conduct surveys and telephone support by making use of past experiences and the results of the survey is what we can do to look after the health of prefecture's residents. Last but not least, I want to extend my deep gratitude to everyone who supported us. Thank you so much.
Thank you very much, Dr. Oikawa. And this was a report from the field of the telephone support for the mental health, the resilience. And more than expected, a lot of people have gained the resilience after the disaster. On the other hand, the affected people, that the state of the mental health was very bad, and therefore, whether or not they have someone to consult with, and the way to have a consultation makes a difference. Thank you very much. I'd like to introduce the next speaker. And Shirakawa Hospital, Dr. Hirai. And the title is the Lessons from 13 Years of the Comprehensive Health Check. And he's deeply involved in the analysis of the health check. And we are hoping that he will make a good recommendation for the support of the affected people. This is Hirai, and thank you very much for this opportunity. Let me start. So today's presentation, there are three things I'd like to cover. So learning from the 13 years of the comprehensive health check, psychological and burden on diabetes and future perspectives. Thank you. So this one. So this has some overlap with the presentation made in the beginning. And there are 5 different surveys. And today, I'd like to focus on number 1, the basic survey, and 2, thyroid ultrasound examination, and number 3, comprehensive health check. So these are the NCD in which was increased after the disaster. And this is common to the patient I see every day. the outcome, the prevention and the treatment and outcome from the CKD to stroke, heart attack, and heart failure, atrial fibrillation, cancer. These are the developed symptoms, especially diabetes, are inducing the factors. And for obesity, and which is upper area, and the non-obesity area, there are mainly two channels. For the obesity-related one, is that the physical obesity and also the high TG and low HDL and the hypertension. And the non-obesity channel is described on at the lower part: smoking, LDL cholesterol. And after the disaster or earthquake, how the symptoms have changed. For the younger people, younger than 15, and this one, by obesity, that the NCD and the dyslipidemia increased. And the orange part, and the obesity and the also obesity-related symptoms, and also that the renal disease have increased, and also the IgT. To summarize, what we have found in the CHC was for under 15, after the earthquake, the obesity and the dyslipidemia and also the liver dysfunction were found to a certain degree. Even though that the obesity was resolved, and the dyslipidemia recovery is rather slow. And after or the higher than 15 years old, and the obesity, metabolic syndrome, and the diabetes and IgT, chronic kidney disease, hyperuricemia, polycythemia are increasing. And hypertension, LDL cholesterol value were elevated first, then recover. And next slide shows you the actual diseases and the cause, the root cause factors and the strength of that. For instance, obesity or not. And the left-hand side are the factors. And you see the correlation. For instance, the aging. Actually, as you age, a lot of diseases can be onset. Then, so the hypertension and the diabetes, like how the probability will increase. So, being having the obesity can contribute to the increase of the outcome for the possibility of onset of other diseases. So that can give that great burden on the body. If you have, and also if you have an experience of evacuation, dyslipidemia and renal disease were developed, and the evacuation self has become the exacerbation factor. So because of the evacuation, that the changes of the environment had high correlation to the onset of the diseases. And also the psychological symptoms. If there is a psychological symptoms, and there was a report that led to the liver disease. And next topic psychological burden and diabetes. So I checked the correlationship of the psychological burden and diabetes. I see that the many diabetes patients, so after the earthquake, what happened to the relationship was the area I studied, and generally said that the psychological distress and depression already had the correlation with the diabetes. They have bidirectional influences, and PTSD and it can be, and post PTSD has the risk factor for the type 2 diabetes. So if you have a distress of the psychological area, then the glycemia level can go up, then which can lead to the diabetes. So psychological distress and the state of the mentality were evaluated. And case 6 interview sheet, and also using PCL, I evaluated the state of the psychological conditions. So case 6, what is case 6? And for 30 days, the state of the psychology or the psychological condition for 30 days is described, and using the 6 questions. And if the score is 13 or higher, then positive is the result. So what kind of questions? And whether you are nervous, and do you feel hopeless? And these are the questions. And we do the scoring to determine whether there is a psychological burden or not. And PCL, this is the checking of the PTSD, and this is also similar to case 6, but the questions are different, and this is more focused particularly on PTSD. Number 1, so this the stressful experience, do you repeatedly remember that? And this kind of disturbing dream, do you often have such disturbing dreams? So these are the questions particular for PTSD. For this, 44 makes a positive of PTSD. And case 6 and PCL scores, and also onset of the diabetes, are there any correlations? As a part of the CHC, I have done the survey, and this is a result. And also the psychological burden increased new onset of diabetes among men. How to see this graph is the upper part is K6, and lower part is a PCLS, and for PTSD. The red line is K6 positive. Blue one is K6 negative. And looking at the K6, especially among men, you can see that the relationship. So looking something like this. And furthermore, in order to do the further study, the following analysis was done. What this means is that Kaplan-Meier curve, and for instance, the variables, for instance, the gender and the sex have something to do with the result. So using this kind of model, considering those, K6 positive and negative, whether they have an impact on the onset of diabetes is studied. For instance, model 1, that the adjustment is not made. Therefore, if it is a man, K6 negative person and the positive 1.28 times more likely to have an onset of the diabetes. And for instance, for the multivariable adjustment and evacuation, if you calculate them all, then men K6 positive can stay as a factor to the onset of the diabetes. But in case of the women, they tend to be lower. And in the middle, that the impact of the variable is observed, so PCL, and that was true with the K6 as well as PCL. Even if we understand the impact from the multivariable adjustment for men, and it can be seen as for men that this can be that relatively strong factor of the onset of the diabetes. And what is the actual onset of the diabetes, men and women? And among men, K6 positive people have higher onset rate of the diabetes in all age segment. And in case of women, not so much difference. And for that, it is limited to a hypothesis. And we have done that, given some thought. So the difference of the self-reporting of the symptom. So in this study, K6 13 or higher and the PCL 44 or higher, the women was 70.6% and 67.1%. It is 2.4 times and 2.04 times compared to men. So this self-reporting was higher. So and this has no differences with the preceding studies. And the women tend to have the higher scores. So our interpretation is K6 and the PCL is a subjective reporting. And looking at the precedent studies, in case of women, they tend to overestimate that the pains, and men tend to have report the distress or pain. And that's a mechanism among men. When they report the symptom, there is a likelihood or possibility that the neuroendoric changes are already there. And I pay attention to that. And this is the thought I have given. And this is a citing from the reference document. And this axis of hypothalamic pituitary and adrenal, that maybe that response has a gender difference. In case of men, stress response is a high-level cortisol intervenes. And in case of women, HPA response goes down. And that is related to the increase of the burden of the psychology. So the response to the HPA may be different between the genders. And number three is the difference of the social factors. What this means is that the psychological stress and employment rate and the position of the social and economic status. And about the evacuees, the unemployment had a negative impact on the psychology of men. And 13 years of education level made a difference among women. So higher education level can lower the onset of diabetes. And also the difference of the social factors between men and women can be also one of the causes. And this is just a hypothesis. So going forward, we need to study further on the mechanism, in my view. For women, I'm not discriminating women against women. So the future perspective from the CHC, so what we need to be doing going forward, so how to have an onset of NCD. We have a treatment to prevent the NCD, and because of NCD, that the kidney disease and other symptoms can be brought, and at the end you have a lowering of the functions. And before that, the inappropriate social factor such as the lifestyle, there are things that you can resolve on an individual basis, and there are some factors you cannot do on individual basis. To be specific, what you can do on the individual level is that is to have a healthy lifestyle, and the literacy is important because there are a lot of information. So relatively evidence-based, accurate knowledge is, or the right knowledge is important. On the community level, what you can do, for instance, the provision of the healthy food, and also setting up the system to support the healthy life. These are the things which can be done by the community or local government and the national level. And for instance, the budget to create the healthy lifestyle, and also R&D to support that. In our survey, I think this is an area we can serve. And going back to the previous picture, so what shall we do about this? And the renal disease and the cancers, this event, to contain or prevent them has to be done by the clinical practices and the research and the support. So if you are obese, then you have to make a correction of that. So by correcting the obesity, then people may think this disease will be gone. But to repeat myself, but for instance, smoking, which is not anything to do with the obesity, or the diabetes, not related to obese. So for such diseases, you need to have a right medication so that you can have a right treatment which is based on the evidence. For diabetes, the losing weight is not sufficient. So if necessary, you need to have a right medication and also the instruction for or guidance for the lifestyle. And this is a summary. There may be some overlap, so I'd like to make it brief. And the CHC's role, and number one, that provide opportunity for health checkup and getting the health check and receive the feedback. This is bilateral information is very important. And number two is a close cooperation with the municipalities. Knowledge gained by the CHC can be returned to the municipality and the individuals. And the health seminar is strongly supported by Fukushima Prefecture. And as you can see, the number of participants is increasing. And that means, to a certain degree, the community members' awareness is gradually increasing. So we would like to continue this kind of support bilaterally. And number 3 and 4 are similar, and the knowledge and information gained need to be published in this kind of place or the papers. And number 5, the specific proposal for CHC, if there are such findings, we need to make a proposal of such things proactively. And this is a summary for today's presentation. Number 1, the lessons learned from 13 years of comprehensive health checkup. I talked about the disease impact. On the number 2 is a psychological burden and diabetes. The mechanism need to be further investigated, and also the future perspective from the CHC. I talked about that briefly, and that is all. Thank you very much for your attention. Professor Hirai, thank you very much. And for this 13 years of health checkup was the theme. And the data from the health checkup and that data was linked with the other survey, and especially you have given that detailed thought on the relationship with the diabetes. I would like to entertain the question at the last part of the session. Thank you.
It's time to resume. We will have discussion for session 1. Dr. Shimura, Dr. Maeda, please start. Thank you so much for 3 doctors who have kindly presented. And thank you for our audience for a number of questions. We have received so many questions, so I will primarily focus on the questions related to the doctor's presentations. For the questions we were not able to answer today, we might publish our responses on our website. All right, first, in the order of presentation, first we will share the questions for Dr. Suzuki. The first question. We understand the need to expand cooperating medical institutions for TUE, even to outside of the prefecture. What are the hurdles for an institution to become an institution for TUE? Well, thank you for your question. It is important to expand the number of cooperating institutions. However, first, the institution must have a basic knowledge about TUE. And so we have stipulated certain criteria. They have to have experts for the 4 major thyroid-related medical academic associations. They have to be qualified as a specialized doctor in these academic associations. For Fukushima, we've got the joint committee, and so under the joint committee initiatives, that doctor who belongs to that institution needed to pass the qualification examination. By doing so, I believe that we can maintain the quality of TUE. You are still looking for institution to join your initiative. Yes. When I have an opportunity to travel to Hokkaido or Okinawa, for example, I will try to look for eligible institutions. Let me move on to the next question. I've heard that there are cooperating medical institutions for TUE other than FMU, but I do not think of any in quite a few, only a few number of them in Aizu and the Minami Aizu area. Is there any way where I can take TUE in other than specified medical institutions? Thank you for so much your question and interest. As you know, we are under challenge in these regions. And for such areas, we will set up more public venues than the other regions. And also, for this year, we have set up public venues in Kitakata and Minami Aizu. And for Kita Aizu, we will always set up examinations for autumn round. We will keep our effort to expand cooperating medical institutions. At the same time, we will do our best to enhance the conveniences of our conventional medical institutions. Thank you. Next, may be quite a challenging question for us. The TUE result so far has confirmed that there is no significant differences in the health effect according to the dose of radiation. So what is the benefit of continuing these initiatives, especially when you have to secure a certain resources and staff members with this scale? Thank you. Thank you so much for your question. We do not consider that there is those impact effect. So it might sound a little bit contradictory, but I believe that it is worthwhile continuing these initiatives for a longer period of time. For one thing, some of the residents want these initiatives to be continued. And we do not want to eliminate for residents to have these opportunities of having this examination. Of course, we have to ensure certain resources and staff numbers, but I do think it is important to continue these initiatives. Well, availability of such opportunities might ensure peace of mind for the resident. Well, another important point is that the resident might want to take an examination at a later phase of their life. And for example, when they experience marriages and will have a child, they will turn up to TUE, although they did not before. So for such changes of their mind, we have to continue providing opportunities. Thank you. The next question. In the presentation, estimated radiation dose was presented. What is the estimation method? And how reliable is the method? Thank you so much for your question. It might be a little bit outside of my specialty, but regarding the estimate of dose, in the basic survey, we made an estimation by asking questions of the resident behavior post-accident and calculated according to that information obtained. And regarding the calculation method, we have disclosed the estimate in internationally well-known academic literature. So we consider that there is a certain reliability. How do you find that? Yes, it is an estimate and not actual measurement, but the estimate is based on the actual behavior pattern of the resident, and it is an internationally recognized method. Thank you. We've got only 2 minutes to go. Now, 18-year-old at the time of the disaster turns 30 years old. Rather than radiation, aging, or other lifestyle-related factor might likely to cause thyroid cancer. What is your opinion with this respect in the future of TUE? Thank you so much for your question. Exactly what you said. The detection rate of thyroid cancer will increase over age and also other lifestyle-related, for example, the habit of smoking or obesity. They will present risk factors for thyroid cancer. Some people might develop the thyroid cancer because of these factors. It's important, I think, to keep analysis of the relations between these factors and the detection rate of thyroid cancer. Thank you. There are other questions asked for Dr. Suzuki, but for the sake of time, let me conclude the question session for Dr. Suzuki. Thank you, Dr. Suzuki. All right, please move on to the next. Okay, next one is Dr. Oikawa, who have actually received a number of questions. So let me focus on the questions that is related to his presentation today. The first one is about the pandemic and the school closure during the pandemic. And I am really concerned about its impact on the children. This person is working for schools. Have you received any consultation request regarding school closure from mothers in your telephone hotline? And if there is any, do they relate to the experience of the disaster in 2011?
So concerning the questions or the consultation requests for the children who were not able to go to the school because it was shut down due to COVID. Yes, there were many questions from the people affected. Mother said that they play games all the time at home, and the brothers and sisters fight more often than before because of the impact from COVID, because they were not able to go to school, and also that parents are working from home. Because of the multiple issues, families had to stay 24 hours a day, and parents saying the kids study more, used to not stay late at night, and there were more fights or problems between parents and also children, and they had more stress. That's why they had some the argument. So right after March 11th, the relationship with the disaster, well, I can talk about the difference that I noticed between COVID and also the March 11. Right after March 11, the questions we got was that how long do we need to evacuate, and when can I go back to my home? What can we do with our children's schools, and how long do we have to stay here? So that the parents and also children both had those concerns and anxieties. And there was an influence from parents to children. If they have those anxieties, it could impact their children. But under COVID, and their kids were not able to go to school, and the people did not know how long the impact was going to last. But they felt the necessity in order to control or prevent the infections. They had to do it, and they knew what they needed to do in order to reduce the impact from COVID or infections. So right after March 11th, parents and also children did not know what to do. That caused their anxieties. But under the pandemic, people were not able to do what they wanted to do. That's why they were so stressful. and also some uncertainties towards the future, how long this situation will continue. People did not know that. So, through telephone outreach support, what kind of advices do you give to those people, or what kind of advice was effective? From my view, it's better to have a communication between parents and children. Of course, they had fights, but the question is how to overcome those issues and how to deal with the situations going forward. Maybe they can, communicate in a different way, or they can change how to talk, and they can think about solutions together. Not to like thinking together, thinking about specific solutions rather than reducing communication. And do you have any tips how to better communication? So you need to have think about how to better communicate. And next question is, there are people who did not have anyone to consult with, who were not able to seek advice. Was there any trend concerning the age groups or genders concerning the difference? In my presentation, I also covered the paper written by Dr. Horikoshi, the people who did not have anyone to turn to. He talked about the characteristics of those people. According to his paper, male and also people in the middle age, and also people don't have any leeway, financial leeway, and living alone, and also older people living outside of prefecture. So those are the people did not have anyone that they were able to get advice from. That was the tendency, and I am male too. So I think this, Dr. Hirai has done some analysis over different male and those women and the weakness and among men. So maybe he can cover that question. And let me move on to the next question to Dr. Oikawa. So among the respondents, there were some people who did not want to receive communication by phone through the outreach, telephone support. They prefer text message or chat. Maybe there are some people who prefer such non-telephone call communication. Do you have any countermeasure? Yes, through our outreach and telephone support, we found some people who did not want to receive such a support over telephone because they were not really good at it. And we found such answer in our questionnaires. And the young people, they often use line, like a chat-based communication. And they have more affinity to those. It's easier for them to access to such a communication mean using such a media. In order to reach as many people as possible, I think that's one important aspect. However, unfortunately, based on the manpower we have in our team and also prepared the preparation to develop such a system, it takes time to build such a system. So it will be difficult to implement such a countermeasure this year or next year. But as I said, we want to be able to support as many people as possible. And if there is a good tool available, then of course it will be meaningful. So we want to further discuss the possibility. So that should be your major challenge in the future. And concerning how to provide support, next question is also relevant to that. There are people who did not respond. How do you approach those people? The people who responded to the survey, of course, you can deliver the support through outreach, telephone calls, services. However, who did not respond to the survey, how can you support them? Yes, that's our struggle as well. People did not respond to the survey. We cannot offer telephone support to them. That's why we need to focus on how to improve response ratio. That we value that. For example, not only sending out paper-based questionnaires, and we make online response, online method available so that the younger people can respond to the questionnaires. And also, we can send questionnaires to everyone who are covered, eligible to this survey, and we can insert pamphlets and also the tips how they can spend their time in their life. So we try to insert such information as well. Of course, like an educational activity is very important. So we just sent out the survey lately. If you have anyone who are eligible to the survey in your neighborhood, then would you please encourage them to respond to our questionnaires? And I strongly want to ask you for your support. I have another question. There's another question. So Dr. Oikawa used the term resilience, and there are some questions about the terminology resilience. What's the definition of resilience? Can you talk us through so that we can understand what resilience means? Thank you for the question. So the word resilience, it's very difficult to translate that word into Japanese language. I read some books, but we were not able to find the good translation. And in my presentation too, that was my pain point. Like resilience, power to recover, flexibility that we can, when the force is applied, you don't break down. You can, recover from the previous state. So that's the power of recovery, ability to recover. This is my private view. If you have experience or the successful case that you were able to overcome certain challenges, using that knowledge, you can, positively think how to overcome your current issues. I think that's how you can gain resilience. This is only my personal interpretation of resilience. You can stay positive, in order to address the stress you are feeling now. That's what you are trying to practice too. Yes, that's my private view. Just one point. This is relevant to Dr. Harai's presentation, but when you say resilience, people think people who are strong, people who are not defeated. That's not resilience. You can, you can accept that you cannot do it or you are weak, and that can lead to resilience. That's often said. So I want to avoid any miscommunication or misunderstanding on the word resilience. So Dr. Hirai, your presentation was quite academic and very, sophisticated and difficult to understand. So including that point, I want to ask you to answer the following questions. So Dr. Hirai, in your presentation, you stressed that, about the diabetes, how to scrutinize, to examine the diabetes, or if that the women, if they are more tolerable, they have a higher tolerance. I understand that you are going to, do you have any plan to delve into this in your joint research going forward? So Dr. Hirai, would you please, talk us through about the result of your research? About the difference by gender, sorry. The mechanism we expect is only a hypothesis. The symptom, from a biological perspective, women are prone to have such symptoms. They try to consult with others or trying to report. Women often report that or consult with others. Men are prone to not to consult with others. They just try to be patient with their symptoms. So men don't share their problems with others. Maybe that's one of the big impact. And that was a finding in the research too. And also socially, they become isolated. Maybe that was the reason.
The coping, maybe the difference of the coping, the difficulty between men and women are different. Actually, that the original chairperson in this section was the female researcher, but as a man, maybe there should be something that I should reflect on. Another question related to that. that the psychological burden and cases, and that there was a very significant correlation among men with the diabetes. Is there is there any impact from the experience of evacuation? So to give you the conclusion first, so I have to do the analysis, and there may be some differences in the preceding studies. Not this earthquake, but the data from the worker, the stressed male tend to have more likelihood of onset of diabetes. There was a such finding, but I have to do more research to give you the more concrete answer. And number two, that the factor, one of the factor is the experience of evacuation. That's true. And so the presence of the evacuation experience is reported as the more frequent or the higher possibility of onset of diabetes. And there was such a preceding paper. And probably there was an impact, but as a result of this study, rather than the experience of evacuation, more the stronger factor was gender difference. I understand. And another thing is that the result of this CHC, how do you use the result, or how do you think the result can contribute to the enhancement of the healthy life of the residents in Fukushima Prefecture? So the bidirectional is important. For instance, the lecture on visiting basis, and that is, I think we are in the phase that we are gradually developing that type of occasions, and we are seeing gradual increase of the people, increase of the number of people who participate. Maybe getting the feedback from such participants will be more important. As Professor Oika said, so the East Japan earthquake, Great East Japan earthquake experience was useful for overcoming the COVID. That's what I understood. So this kind of knowledge obtained, as much as possible, I think it is better to have sharing of such information face to face. And I think that's an important procedure. Since we have some time left, Professor Oika or the Hirai Sensei, the perseverance of the men, and the men tend to be not very good to talk about their weakness. And what type of approach do you think is good? Professor Oikawa, what do you think what men can do? So the difficulty of consulting with others among men, maybe the background is that the strength and the frequency of the connection to the society or the broadness. For instance, if the man is just have a relationship at the work and family only, and it may be difficult for them to have to talk about their difficulties. But for instance, if a man has a lot of hobbies, and if this man has other group of people who see through golf, maybe that type of things can create that easier environment. So the so-called third place. So to create the place there you feel comfortable with, it may be important. So about the prevention of the diabetes, for men to become aware of the importance of such prevention, is there any input? I can only share my personal opinion. So actually, discontinuation of the treatment for diabetes happens all the time. So and when they come back, that the hemoglobin A1B was 10%, and they may have a psychological issue. So from my point of view, the single men who are older in age tend to have such a situation. So as Dr. Oika said, the connection to society is important in my view. If this person had a stronger connection to the society, maybe he should have come to me earlier than today. And that's one point I'd like to share. And another thing is that when I see the male patient, what I often say is that diabetes is an important thing, but the frail and sarcopenia, this sustainment or the maintenance of the muscle is also important, also in Japan. So the lifetime sports, I often ask that, do you have any favorite sport? I often ask that. And they say, when I was young, I was playing tennis, and I was playing table tennis. So so-called lifelong sport may be beneficial so that they can exercise and have better communications. So lifetime sports, and if they have some exercise as a sport, they can do lifetime. And in my case, I like playing golf and batting center for the baseball, and that's not very popular. But if you go there, you can hit the ball, and you can try to do better. I see your personal life. So lifetime sports may be good. Since it is time, do you have a final comment? And today, we segmented some time for per area of a discussion. Our CHC will continue so that we can share with you the result of the FHMS. Thank you very much for your participation today.
それでは定刻となりましたので、
Now allow me to restart session number 2, open session. Dr. Nolet, please go ahead.
Session 2 will be chaired by Professor Ohira Hiromasa, whose biography shows a long commitment to Fukushima and high-level positions in the Fukushima Health Management Survey and our Graduate School of Medicine. Professor.
はい、皆さんはじめまして福島大の大平と言います。前半の
Thank you so much for your kind introduction. How have you found the discussion in session number 1? I hope it was quite insightful. And session number 2 is open session. And we will make it further understandable to the contents. There are 2 presenters, and one will focus on the miscarriages, and the other focuses on post-disaster management. The first presenter is Dr. Fujimori. his presentation title is "Do you know about miscarriages and congenital anomalies and the result of the pregnancy and birth survey?" Thank you, Dr. Oshihira, and good afternoon. My name is Fujimori of FMU. I am a gynecologist. Let me talk about miscarriages and congenital anomalies, and I am not really sure. You might think that it has nothing to do with radiation exposure and its health impact. But right after the disaster, there were some insensitive rumors that if you give a birth to a baby in Fukushima, the baby will have a higher percentage of congenital anomalies. And I remember having received such a phone call inquiry, and I thought that we must conduct then a full-scale survey. So today's presentation is what is miscarriages and congenital anomalies in the first place, and I structured my slide in that way. First, let me ask you this. How often do you think miscarriages occur? Regardless of maternal age. Actually, maternal age has a tremendous impact on that. I will talk about it later. 0.1 to 0.5%. Raise your hand. Oh, it's hard to raise your hand. Rate 0.5 to 1.0%. Who think 1 to 5%? 10 to 15%. 20 to 30%. The correct answer is 10 to 15%, maybe higher than initially thought. Miscarriages are not something special. It quite often occurs. Okay, let's move on. Do you think which do you think is the most common cause of miscarriages? Chromosomal abnormality in the fertilized eggs. Endocrine disorders such as glucose intolerance, thyroid, and dysfunction of the mother. Autoimmune disease, antiphospholipid syndrome, for example, or connective tissue disease comorbidities. Number 4, intrauterine infection. Actually, this was quite often the case long time ago. The 5 is external factors such as drug use and exposure to radiation. The right answer is 1, chromosomal abnormalities in fertilized eggs. This is quite clear. The third question, how often do you think congenital anomalies occur? As is often covered, this question, regardless of the maternal age, 0.1 to 0.5%. Dr. Yasumura covered this, and the right answer is 2 to 3%. So 2 or 3 out of 100 the babies will have congenital anomalies. So this is not rare. When a woman gets pregnant with a baby, that they would never assume that the congenital anomalies would occur to my baby, but it is not rare, so it doesn't come as a surprise to me. So since it is 2 to 3% occurrence rate, so it is not rare. Next question. What do you think is the most common cause of congenital anomalies? If I may tell you the right answer, single gene disorders. The reason is not known. For example, heart disease takes place 1 out of 100% babies. And if that woman have babies again, 4 to 5%, so 5 times higher. And the third baby will have 10 to 15%. triple-fold increase. Single gene disorder is a hereditary disease that follows the Mendel's law. It is result of multiple genes. If there is an existing condition held by the mother or the father, the probability will increase. Multifactorial genetic disorder is rare, and drugs impact is quite small. And then what is abortion? Definition of abortion in Japan is defined as the termination of a pregnancy before 22 weeks into gestation. The definition varies by country. All throughout Japan, termination of a pregnancy before 22 weeks in gestation is abortion. There is induced abortion and spontaneous abortion. This is an excerpt from textbook. Perinatal maternal science. Spontaneous abortion rate will take place at 10 to 15% of clinically confirmed pregnancies, and 2 or more miscarriages occur in 1 to 2% of women, and 3 or more occur in less than 1% of women who get pregnant, and 38% of pregnant women experience miscarriages. And these are the knowledge that you have to equip with if you want to practice as a gynecologist. And the frequency of miscarriages is greatly dependent on the mother's age. 50% or less for those aged 30 or younger, 20% for those aged 35, 40% for those aged 40, and 80% for those aged 45. And this is a very important data. You can see the graph. Advanced art, advanced reproductive therapy, and in Japan, you have to register every single case so we can get such data. On the horizontal axis, there is the year, so it's quite clear that it is on the increasing trend. And broken down into technology. And recently, there is a spike. As you know, 3 years ago, these art came under national healthcare insurance coverage. The green part is increasing particularly, and it is a FET or frozen embryo transfer. You will get your eggs frozen and preserve that and transfer that when you are ready. And this is FET is increasing explosively, and about 1 out of 10 babies now is coming out of art. And what are the peak age of these art? And treatment age peaks at 42 years old. However, the peak number of cycles leading to birth occurs at age 37. The age 42 comes as a surprise, maybe not for you, but for us, it comes as a surprise. Maternal age on the horizontal axis, and the green shows the birth rate of total treatment. At the age of 40, 1 out of 10 can give a healthy birth to a baby even with art. And at 45, only 1%. My message with this slide is quite clear. Miscarriage rate is 10% among young ones, but increase after age 35, and about half will result in miscarriages when the maternal age is 45. Even with art, maternal age is a determining factor of miscarriages occurrence rate. Causes of miscarriages. There are many. Of course, the maternal health impact, but they are rare, and most of the cases, miscarriages occur due to abnormalities in fertilized eggs. There are another condition called recurrent pregnancy losses. The person will get pregnant, but miscarriages recur and cannot result in birth of a healthy child. And fetal chromosome abnormality stand out as the factor. And chromosomal abnormalities in couples account for 10%. These couples will have repeated miscarriages. Miscarriages and chromosomal abnormalities. About half of them is trisomy, which most well-known type of trisomy is Down syndrome. But the trisomy, 16 trisomy and 22 trisomy are also known. They only have 13 and 18 and 21 to be born as a human. If you have a 16 and 22, you will end in miscarriages. And the 45XO is called Turner syndrome and a relatively well-known condition. 13 and 18 trisomy and Turner syndromes will result in birth. But there are so many chromosomal disorders whose pregnancy end in miscarriages. And why there are some fertilized eggs with three chromosomes. This is oocyte, and they will start meiotic divisions. And when non-disjunction occurs, a chromosome cannot separate successfully. Non-disjunction occurs, and as the mother ages, more frequently non-disjunctions occur. This is called an aging of eggs or oocyte. With the maternal age, probability of non-disjunctions gets higher. As a result, eggs will have one chromosome higher than the sperm's chromosomes. As a result, the fertilized egg will have 47 chromosomes or autosomal. As a result, they will have autosomal trisomy. And if 13 or 18 and 21 trisomies, they will result in congenital abnormalities. When you use owned eggs and receive art, the success rate of per embryo transfer declines according to maternal age on the horizontal axis. But if you use a donated egg, success rate would not change a lot according to maternal age. For example, you can use a younger one's embryo and get it transferred to yourself, and then you can give birth to a baby without miscarriages, although it is not currently allowed in Japan. So I want to say that the maternal age is the determining factor if you use your own eggs. Let me next talk about congenital anomalies, which refers to the disabilities or diseases that a person is born with and classified into two types: morphological abnormalities, and functional abnormalities. And here is morphological abnormalities, which causes abnormalities in heart and lips and limbs and functional disabilities is effect of bodily systems and functions and due to the levels of specific hormones or enzymes.
So this is the reasons behind the congenital abnormalities, like a single gene abnormality. Sorry, numbers disappeared. I thought it was corrected. However, 40%. That's a single gene mutation, and 25%. That's due to chromosomal abnormalities and environmental and the drug. That's 5% of the congenital abnormalities. So it's the environmental factors are less or small, and single gene. Like a congenital heart disease, we ask students. We ask them if that's congenital. That's the answers of most of the students. However, this is one of the representative example of a single gene abnormalities, and also spina bifida. This is said that if mothers take iodine, then that can cause spina bifida. And environmental factors like cigarettes and alcohol, those are mostly related to the developmental disorders, and radiologies like spina bifida and others, and the microcephalus. So miscarriage can happen 10 to 15%, and also chromosomal impact is the biggest impact, and congenital abnormalities is about 2 to 3% with newborn babies. So efficacy is low, and the single gene is the most biggest impact, and the radiological impact is limited. So I want to focus on the overview of the Fukushima Health Management Survey now. There are 5 researches, and our research is the survey is one of those. Not only conducting survey as needed, we can offer telephone support and also visit support to the pregnant women. And we are still doing this for the people who need this kind of support. Sorry, letters are not really clear, but so that's the number of birth. It was 16,000 number of deliveries. Now 2020. So that's 2021 and that's 2020. In Fukushima Prefecture, the number of babies born in the prefecture has been less and less. 2023, it's below 10,000 babies. And the response rate is about 50%. This is not the issue only in Fukushima Prefecture. As you know, throughout Japan, we have lower birth rate and aging society. So we have less and less new babies. So this is about the incidence of congenital abnormalities. In Fukushima Prefecture, around 2 to 3%, that's a national average. And Fukushima's number is within that range. And after the disaster, having a higher ratio of babies' abnormalities, that was not the case based on this data, the fetal anomalies. Next data is the comparison between external radiation exposure dose and also the babies. And this is linked with our basic survey. And what x-axis? The first 3 months external radiation dose showing in y-axis horizontally, and you can find different data points. There was no correlation or relationship. Having higher external radiation exposure, did you have more abnormalities with the babies? The answer was no. So about congenital abnormalities, what are the causes? Is there any relevance? Comparing external radiation doses and congenital anomalies, cataract, and also neural tube defect, and also microcephaly, it has been said those are related to the amount of external radiation doses. However, the number of cases were a few, but there was no relationship. And another point from this data is there were different babies born, but 2 millisievert. There was no baby with over 2 millisievert of exposure dose. There was no baby with higher than 2 millisievert for the radiation dose. Minyu and also Minpo newspapers covered there was no abnormality with the newborn babies, and in national newspaper like Asahi Shimbun and Yomiuri Shimbun, it was captured that there was no rise in the number of congenital babies with congenital abnormalities. So, like miscarriage and also abortions, we cannot get that data in FHMS. In order to support this, all the OB hospitals within Fukushima Prefecture, we conducted a survey how many people had miscarriage or abortion. We have collected this data, and the response rate was 100%. For the newborn babies, we have vital statistics, birth certificate. We get the data from national database, and we use that data. Babies after 22 weeks of pregnancy, we use this data too. I know this is quite complex. And let's skip that page. And the upper part, we have the induced abortion, and also on the top, and spontaneous abortion at the bottom. The one you see with the gray, that's the. So the shaded area shows the upper and lower outliers calculated from the quartiles, and it's above a little bit above 10%, more or less. So after the disaster, there was no increase in the spontaneous abortion. The upper part, that's induced abortion data. After the disaster, when we had this discussion over this topic, the journalist came to me and told me a question that, oh, it looks like there was a slight increase after the disaster, which concerned me a little, but because people did have such a concern. But actually looking at this data, it was in May and also June, around that time of the year, every year, you see a little surge in the number of people who receive abortion, which, because this is a cyclic data, we have ups and downs in different months. And looking at on a yearly basis, there was no major change even after the disaster. So abortion, there was no particular increase in the number of abortions. That's what I reported to them. So this is a result of pregnancy and birth survey. The incidence of congenital anomalies in Fukushima Prefecture was at the same level as that was reported generally. In the maternal external radiation doses, there were no significant changes in the proportions of spontaneous and induced abortions since the disaster. That was the conclusion. And this is my final slide. I have been talking about this topic over 10 years, and I have been using exactly the same slide at the end of my presentation every time. So regarding no-dose radiation exposure, simply stating that it is safe, and we knew that from the beginning. But every time I mention this, and people ask me to show them data, but I did not show the data. But since it has been over 10 years, by showing this kind of data, having a baby in Fukushima, it's safe, and the people can have peace of mind. It's reassuring. The people can have a sense of reassurance having a baby in fresh Fukushima, because we have this 10 year data for a certain period. We can clearly say that it's safe to have a baby in Fukushima. That's all. Thank you very much for your attention. Okay, thank you very much, Dr. Fujimori. Over 10 years, you have done such a detailed survey on a constant basis. People can have baby safely. It's safe to have a baby here, and also the people, it's okay for them to feel the reassurance of having a baby here. So I think this is a very strong data to support such a feeling. Thank you very much for your presentation. Would you please give a big round of applause to Dr. Fujimori once again?
Now, Dr. Tsubokura, Masaharu Tsubokura, and the professor of the health management lecture. So after the earthquake, he came to Fukushima, and since then, he is always close to Fukushima, and has been very active for promoting the health for the residents of Fukushima. So today, I would like the doctor to talk about the protecting health after disasters, the evolution of post-earthquake measures, and the preparation you can do. You can start now. Thank you very much for your introduction. And thank you very much for this opportunity to speak in front of you. My name is Tsubokura, and I would like to talk about the protecting of the health after the disasters. And I'd like to look back regarding what we have done to protect the health. And we are coming towards the end of the session, but please stay with me. And first of all, when you hear disasters, what do you think of? What do you have in mind? Is it earthquake or typhoon or flood or fire or snow, the volcano, and infectious disease? And nuclear power plant is one of the disasters, even if it is man-made. So Japan is full of disasters you often hear, and Japan is very unique. And what is unique is that various disasters are happening within the radius of 100 kilometers, within that the 1-2 hour of drive distance. Unfortunately, if you go to Aizu, then you see a lot of snow, and going to the ocean, there's tsunami and earthquake. And for earthquake, I'm sure you know a plate. So plate moves and the tsunami is generated, like Great East Japan earthquake. It's a plate type, and also the fault, like Noto Peninsula earthquake. So we have both types of earthquake, and we have typhoon. And since we have many wooden houses, there are fires. So all of the disasters, you have to be familiar with all disasters, and that they happen repeatedly. So the affected people, 90% of the affected people by the disasters are Asian. And there are many disasters in Asian countries. And furthermore, in Japan, we have a familiarity to all of those disasters. So we have to have a lot of knowledge about the disaster. And today, after the disasters, I say, in case of earthquake, let's hide under the desk. And for tsunami, what should be doing is what you often talked about. And after the disasters, what type of health issues we have to consider? In this kind of health management survey, there has been repeated the findings. So in the beginning, I'd like to talk about disappointing things, like what happened and what happened. Then after 15 years, based on that knowledge, what has been improved is also what I'd like to touch upon. And from days to weeks, a month to years, and several years and later, and there's the exposure, the radiation exposure, and there are some current incidents at the Hamadori area too. And in the beginning, from days to weeks, there are issues with the evacuation places. And there may be a thrombosis because you don't move so much. And also the high hypertension, and also the related death from the disaster at the nursing home, that was often talked about. And when we moved to month to years, then there was a temporary housing issue, and you move several times, and there may be an impact psychologically, and higher risk of the diabetes or obesity. And there are many people who cannot have a health check for cancer. And after years, the nursing issue. Nursing fee is different from the municipality, so the cost will be higher. Hamadori of Fukushima Prefecture is one of the highest charge you are asked to pay for the long-term care, and there are discrimination and also the stigma, and there are some recovery to that too. But there are many health-related issues. But the Fukushima Health Management Survey, the basic survey, was looking at the external exposure in the first 3 months, and that is the most important thing. And like the thyroid cancer, as often pointed out from the Chernobyl, so the impact on the psychological aspect and the lifestyle-related disease are quite critical. Impact on them is quite critical, as Dr. Fujimori mentioned. And with the various issues, what's most important? I shouldn't say this is important and this is not so important, but we have to make sure we understand the important part, so that to share with you once again, these efforts are ongoing still. So what happened is something that we can talk about, the evacuation of the nursing care home. And for the evacuation process, a lot of people have actually died. And from that, the disaster-related death has become the buzzword. So for Noto or earthquake, from the next date of the earthquake day, we made very much effort to reduce the number of disaster-related death. So that kind of momentum was very clear. And that's something that I would like you to be aware of. I will not talk about the result of the psychological impact, but in the beginning, 15% was the suffering for the psychological aspect, but it went down to 5 to 4%. And it may be due to the time and also the follow-up assistance by making a calls, and also the lifestyle-related disease and the diabetes. Fukushima has a lot of good fruits, so it may be difficult to reduce the diabetes. But we have made an effort to lower that. And we have many classes or lectures to work on the health. So these are important things. And because of the experience we had in Fukushima, so this is better known to other regions. So the health issues related to disasters, it may depend on not only the intention of the individual or motivation of the individuals, but now it is changed. That those are the things that everyone has to do because of the experiences in Fukushima. And having said that, especially Fukushima Prefecture and the Hamadori, what do you know what happened to the average longevity? Actually, the lifetime is extending. And that's something I would like you to be aware of. So from my point of view of sending information, I talk about the bad things, that what's not being achieved and so on. One of the things is that I like to also talk about the improvement we have seen. I would like you to be aware of the improvement, and children become more obese and the physical strength went down. However, that's recovered. Actually, that the obese issue has been recovered among children because of everyone's effort made. And Hanshin Awaji and Great East Japan, and there are Noto Peninsula and as well as Kumamoto. So there are changes in the Japanese disaster. At the Hanshin Awaji, that older people's percentage is 13%, but Great East Japan earthquake 23%, and 47% at the Okunoto Peninsula. What I like to say is that the necessary measures for the disasters and also the people we have to cover are changing. So what triggered was a nuclear power plant accident, and that's one of the results that the Fukushima Health Management Survey showed. So what we need to think about at the time of disaster, horizontally, this X is the time, and the Y is the strength of the physical condition. So the condition goes down, but we can recover or we can get used to the status quo or current situation. So the situation change happens repeatedly at the time of disaster. And that was true with the Fukushima Health Management Survey. And for instance, if you move to the temporary housing and also move to the public housing and move another location, in the process of recovery and reconstructions, and the environment of your life changes. So the vulnerable people who cannot adapt to the changes of the environment can be impacted more, and at the end, the state of the health can be deteriorated. So gradually, in some good part is taken away. So since we have such experience, the anti-disaster related to the nuclear power plant is also the type of work I do. So I talk to the national administration-related people and the Fukushima administration people. Then, for instance, knowledge of the radiation. Actually, Fukushima has a lot of knowledge. You may think we only know about the nuclear power plant accident, but other high-level radioactive waste knowledge, we do have knowledge, a lot of knowledge in Fukushima. And I cannot say that's sufficient, but that's the situation. So in the last 14 years, we are making a very steady step. So that's also something that I would like to convey to many people, and starting from the Fukushima residents. So gradually, we have to be also aware the health condition is going down gradually. With this knowledge, I'm hopeful we can continue the Fukushima Health Management Survey. I have to talk about the radiation, so let me talk about this. There's external and internal exposure. You may think, oh, again, but please stay with me. And these are the radiation-related situation. For the last 14 years, I am giving that class lecture to the elementary and junior high school student. In the beginning, the children became serious because of the accident, but then they got bored of that same story. So you came here to say we are safe, right? And that's the response. And that situation continued. But now it's past 10 years. What's difficult is that we have many people who were born after the earthquake. Why do we have to study that? And the children sometimes look blank, like for us to learn about the World War II. So we are seeing the increasing occasion to see such responses. So this may be seen as a past incident. But what's good about this is Fukushima has much more knowledge about the radiation. That's very clear and true. So the knowledge about the radiation, such as external exposure and internal exposure, so radioactive material emit the substance, and Becquerel and Shea-belt, and which shows the strength of the radiation. Shea-belt is how much exposure dose is given to the people. That is the impact on the people. And Becquerel and Shea-belt are the common words. And sorry, this may be difficult. Rhenium is in that nuclear reactor. This material is used. If the neutron is hit, then there is a fission of the nuclear. Then a new neutron is born. Then there is a fusion again. At the time of fission, there is a thermal generation, and that heat generates the turbine and makes the power. And this kind of knowledge is known the best among the residents of Fukushima Prefecture. I don't think it is this knowledge is enough. I hope this will be better known by the people. But for the last 14 years, we've been repeatedly studied that. So how we can carry over to the next generation and how to keep this kind of knowledge is what we want to think about.
This shows the ground radiation level, which is divided into West Japan plate and East Japan plate. This is another piece of knowledge of literacy. And there is a mountain where you can get uranium. And the first dosimeter was carried over to the Fukushima prefecture before. And when I tell such a story, people who get surprised and feel that what humans' contribution and evolution has protected their present living now. So if you have ever listened to such stories, why not remember that and tell your story to others? This is about background natural radiation in the world, and Japan is not so high. But Japanese people tend to have taken a lot of seafood, so internal exposure coming from food is quite high in Japan. But note that it is not because of tritium, it's because of the seafood. And natural exposure to radiation among Japanese people is slightly higher than the global average. Radon exposure varies significantly by region. Of course, we have been exposed to a certain dose of radiation, but it still stays within the reasonable range and did not go beyond control. You might already be familiar with such data. Of course, an accident happened, but we are really familiar with the data. Another important message you might already know is that no genetic effect of radiation have been observed in humans. But let me go over once again. This might also have something to do with the atomic bombing in Hiroshima and Nagasaki. No increase in cancer or other diseases have been observed in the second-generation survivors or Hivakshas born to parents who are exposed to radiation. And the proportion of children with chromosomal abnormality did not differ between those whose parents were exposed to radiation near the hypocenter and those who were not. And a comparison between thousands of children born to individuals who underwent childhood cancer treatment and the children of their untreated siblings found no differences in the frequencies of chromosomal abnormalities, inherited diseases, or congenital anomalies. Genome analysis of the Chernobyl plant operators and their children, the genome was also sequenced and observed, and there were no differences and no impact or genetic effect observed. And this academic writing was observed in Science magazine. So there are no such effects like skin erythema or alopecia that was not observed in Fukushima Prefecture at all. This is an excerpt from UNSCARE 2020-2021 report, which suggests that the health effect of radiation exposure would not likely to impact human health. Of course, there are some opposition or the different opinions posed to these reports. However, UN report based on a wide range of data suggests such an opinion. And this is another piece of information I'd like to be equipped with. I talked about a genetic effect. And if we ask people outside of Fukushima, how possible do you think that the genetic effect of radiation would occur for those people from Fukushima by current radiation exposure? 30% of people say yes. And in Fukushima, the percentage is a lot lower. That because of high literacy among Fukushima residents. Although I am not still satisfied with that, and so we will continue our effort to disseminate our literacy. Now I am trying to wrap it up. FHMS, as is already noted, addresses a wide range of issues associated with the disaster watching people's health. I am originally from Osaka. I was 13-year-old when the Great Hanshin Awaji earthquake hit the area. I had a grandfather who lived close to Kobe, and his house collapsed, so he evacuated to my family. About 6 months or a year later, on a certain day, he suddenly had a brain hemorrhage, brain cirrhosis, and was taken to hospital, and he was in ICU, and I remember my mother crying very heavily. I didn't know what was happening then, but now I am a doctor and have an opportunity to look at a wide range of data, and all of these memories and information started falling into places. The grandfather was really good at kendo, Japanese martial arts, and he was quite muscly and well-built. And one of the massage therapists once noted about him that his muscle is so strong she can't give her massage. But as he aged, he became obese, and he started taking medicine for hypertension. All these old stories and information suddenly came into places in my mind. I do not want to see the same again, and what should I do? That's my train of thought, and the first step should be to get a high level of literacy. FHMS result is really important. So when a disaster or tsunami hit, how to avoid immediate effect, that might be your initial focus. But after 10 or even 20 years, how you ensure long-term health when the society at large ages. Disaster preparedness and precaution are very important. I want you to know more about FHMS result. It is information, and it has quite a lot of information about how to secure health and healthy life post-disaster period. This is 13 designated municipalities briefing session. We visit these municipalities and have interviews and explain the FHMS result and listen to their request. And we bring it back home and have a discussion and get feedback. And sometimes we have to send the staff members to cater to their needs. And Professor Ohira, of course, gives them a very interesting session regarding yoga with a smile. And sometimes we let them exercise using dumbbells. Since we are working for university, we compile that data and feed it back to the resident. This is a favorable cycle we are currently running. And I want you to be aware on that too. And this is a health seminar which was conducted in Naraha town. And when we say that we conduct such a seminar, you might say, so what? For us, this is an opportunity for us to give you the feedback of FHMS and remind you of the importance of following up on your healthy lifestyle. And with the municipality government, we came up with ideas such as why not give an exercise course. And so this is our way of returning what we have learned from you. Of course, it is important to launch research and to have a symposium, but it is more important to convert the learning into actions and improvement. And this aspect is an important part of our initiatives. Sorry, we are coming toward the end of this session. Summary. No future health effect from radiation exposures are expected, according to a variety of reports. On the other hand, a wide range of health issues must be considered. I don't mean to call something is good or bad, but we should not end our journey for a better health here. There are committee for Nankai Trough disasters estimate of impact. Some of the factor analysis from us is provided to the committee. So it's important to convert our lessons into the action. Now, so many children are born after the disaster, so maybe the type of literacy you might need to be equipped with might change. But we, Fukushima peoples, have one of the highest literacies when it comes to radiation. Medical school student will sit for 19 hours for radiation medicine, and this that hours of study is only available for the Fukushima FMU's students. There are some BMU courses open for year 4 and year 6 students. The national approach to nuclear disasters has significantly evolved. However, we haven't yet reached the maturity. It's important for us to keep providing data and keep providing support to initiatives. Thank you again for your cooperation, and thank you again for your time. Thank you, Dr. Tsubokawa. Based on your experience, you have touched on what center has experienced. It's been 14 years since the disaster. With the support of everybody, we have revitalized the community, but it's important more to continue our revitalization effort. We will stay together to further improve our community. Thank you so much.
Thank you, professors. Let's close by asking the Executive Director of our Radiation Medical Science Center for the Fukushima Health Management Survey to make some final remarks. Professor Yasumura.
閉会にあたりご挨拶申し上げます。
So I'd like to say a few words as a closing speech. How was today's symposium? Thank you very much for staying with us for such a long time. I'd like to extend my sincere gratitude to everyone who supported holding this international symposium. Thank you so much. In this symposium, we had presentations by experts from Japan and abroad, and we were able to hear some valuable information about the activities in the areas of expertise, especially our special guest from Taiwan, Dr. Chen Min Tai. So, including today's this kind of symposium, through different discussions, I understand we were able to, deepen your understanding on our FHMS, especially in session 1. Our university's experts presented the result of FHMS in detail, including the Thyroid Ultrasound Examination, the mental health and lifestyle survey, and a health check. And in session 2, for the first time, we had open lecture to convey the message that people can have a baby in Fukushima in a safe way, and also the actions taken by FMU so far. I think we were able to share such information. Our university are committed to continue supporting the people's health through Fukushima Health Management Survey, and by further deepening global collaborations, we want to keep supporting the recovery of Fukushima and its future. Last but not least, I'd like to once again express my heartfelt gratitude to everyone who supported this symposium, and would like to ask for your continuous collaboration with us going forward as well. This concludes my speech. Thank you so much.
Thank you, Professor Yasumura. Well, together, we've reached the end of this year's International Symposium. To all who have participated, in person and online, from around the world, thank you for your time today, and for your continued thoughts and actions about how to share Fukushima's lessons for promoting health and responding to disasters. Good evening.